come. And Dr. Abhijit Handik is here. He's great cornea and retina surgeon like BP Kashyap, pan ophthalmologist. Dr. Abhijit Handik, please come. Dr. Manish Pandey, aage baithiye. So first, I will introduce Dr. M. Vanati. She is a prolific cataract and refractive surgeon. She does all type of refractive surgery, right from the LASIK to IPCL to SMILE. And today she is going to talk on premium IOL. So I welcome Dr. Vanati. Please, Dr. Vanati, come. Yes. Yes. Oh my God. Vidya? Vidya?
You're good. Yes.
The secretary is Dr. S.K. Mitra and treasurer is Dr. Bhushan. He is our secretary. His name is Dr. S.K. Mitra. He is the and they are the treasurer of Jharkhand Ophthalmological Society. And also, and if I last and they are my source of strength. They support me whatever I do. And now, is Dr. Amit Shah. Madam,
How many minutes? Yes, I'm done. How many minutes? 10 minutes? Okay, so I'll just quickly. Yeah. Good morning, everyone. Good morning, everyone. And I thank the Dr. Bharti Kashyap and the entire team executive of the Jharkhand Ophthalmic Society for having me in this wonderful meeting. And I wish you all a lovely 3 days of academic fest here. I think it's my first time in Ranchi. I do see a lot of our people who trained from our center at RP Center AIMS here at Jharkhand doing a fantastic job, and hats off to all of you and your wonderful society. I am Dr. Vanati, for those of you who have not seen me, because this is my first time in Ranchi. And before the start of live surgeries, Dr. Bharti requested that I just run through the basics or the pearls which are required in premium IOL implantation. Most of us have now shifted our practice into incorporating more and more of premium IOLs in our day-to-day cataract surgeries here. So one thing which I would like to clarify of what you actually mean by premium IOLs. So earlier, I think we talked about premium IOLs. We meant mostly toric IOLs here, but now we have shifted largely from just the adoption of toric IOLs in our practice to a higher element of presbyopic IOLs here. So we have a lot of diaphragmatic, refractive, multifocal, trifocal IOLs, accommodating IOLs, and these we also have the EDOF ones, the modified EDOF ones, the analog EDOF ones here. So a lot of these have now been incorporated into our day-to-day practice. So just words of or just the pearls on what one has to look into before we suggest these premium IOLs to our patients here. I have no financial interest in the mention of any of the products during the course of my talk here. So I think the three imperative steps when one is looking at implanting IOLs is the patient selection, screening your patients for the right, for selecting the right kind of patients and suggesting the right kind of IOL which is going to be suitable for that patient according to his or her lifestyle is going to be imperative in the success of your surgical outcome. 2 is the preoperative ocular evaluation itself. And 3, the most important, is the biometry and the IOL power calculations, so that your well done surgery also goes dot on with an excellent refractive outcome here. So I'll take these steps one by one for you before we just start on our live surgery. So what's important here, I can see in the left top column here, the lifestyle of patients and their visual requirements. That's something which you will need to talk to your patients and counsel your patients before you decide on which kind of multifocal, trifocal, or EDOF lens is going to be suitable for these patients here. For example, a patient with higher needs on higher near vision needs, or a patient has higher intermediate vision needs, the type of job he or she is doing here, and the amount of preoperative refractive error the patient is already dealing with here. So when you're looking at the refractive error per se, or the refractive status of the eye, what we mean is the patient has been a myope, a low myope, a moderate myope, a high axial myopia. Is she a hypermetrope with presbyopia? So these are considerable considerations before you would want to consider trifocal or multifocal IOLs in your patients. Special visual requirements, as depending upon the job profile or the occupation of the patient, needs to be under control. This was under consideration. This was more important when we were using just multifocal IOLs and we had lower ads and slightly higher near ads here. But then with trifocals, I think perhaps we are looking at a near vision quantum, at an intermediate vision quantum, and a distance vision component here. But again, do consider those people who are in professions where they're going to need a lot of good visual requirement in their night lives, like Air Force or airline pilots, drivers, and those job requirements which are requiring a good vision at night and low light conditions. you will have to be aware that when you are advising premium IOLs with diaphragmatic or refractive or combined models here, then the contrast sensitivity is going to be affected in these. So that is a consideration which you will have to take in before you're looking at these IOLs for these patients. Again, the realistic expectations of the patient here. If you're having a type A personality, then you should reconsider the consideration of wanting to put in premium IOL here. So a patient should have realistic expectations. The need for wanting to not to use glasses in the postoperative period comes premium here. Combine it with the visual requirements the patient is going to have, or the realistic expectations here. And if you find the patient is going way off, then such patients are not going to be suitable ones here. Then we will move on to the other preoperative evaluation considerations. I've just put it in a step ladder pattern for you so that it's easier to understand and it's easier to remember here. So astigmatism is one of the key components here. So when you have a preoperative astigmatism which is greater than 0.75 in your patients, these would be probably forgiving if you're considering toric IOL implantations. But if you are considering trifocal IOL implantations, if your preoperative astigmatism is more than 0.7, 0.8, then you will probably also want to consider giving up or taking care of the toric component of these patients here. So primarily what you want to know is the postoperative astigmatism should not be higher than a 0.75. That's going to affect the refractive outcome for near and distance for these patients. So that's something you need to look at your patients, look at before you consider these eyes for premium IOL implantation. Two is the quantum of, or the kind of astigmatism the surface is having, whether you have a regular or an irregular astigmatism. Here, the imaging with a corneal topography is going to be helpful, where you look at the topographic regularity to decide on the regularity or the irregularity of the astigmatism. So again, premium IOLs are not going to give you a good outcome. You're going to have an unhappy patient if you're going to use premium IOLs in such a setup of such a setting of irregular astigmatism. If you're still in doubt, and that is more in cases of post-refractive surgery corneas, in early keratoconus, formifrastae, subclinical keratoconus, steep corneas, thin corneas here, corneas with some amount of opacity here, then look at the higher order aberration. So a ray tracing imaging of the cornea helps you to map the higher order aberrometry of these patients. And if you have a higher order aberrometry which is greater than 0.5, these are going to be very unhappy patients in the event of using premium IOLs for these patients, especially trifocal and even EDOF lenses. You're going to have patients who are not going to be happy here. So these I've already, the corneal ectasia, the post-refractory surgery component I've already covered. The ocular surface disease component, if time permits, I will take it up more elaborately here. So that's something which we do see in a lot of our patients, especially as we are adopting to cataract refractive rehabilitation in cataract surgery in younger and younger patients here because of their increased need for use of digital devices here. And that's where you're going to have a higher quantum of evaporative dry eye disease and a mixed component of dry eye disease, chronic meibomian gland dysfunctions here. So these are patients where you will need to optimize their ocular surface so that your biometry or your keratometry evaluations preoperatively is more accurate, so that it gives you better results or the best dot-on results in the refractive outcome. A word of caution is whenever you're seeing a posterior segment which is not optimal, where your optic nerve is compromised, whatever the pathology, be it a glaucomatous damage, be it an optic neuropathy, a post-AIO in here, patients with macular disorders here, or patient age-related problems. These are all going to be a definite no for considering your premium IOLs here. So that's something which is very important here. The pupil size also. So when you see very, very constricted pupils, that's going to affect how the patient is going to behave in different light conditions and and also the visual improvement achieved for near, intermediate, and the distant segment is also going to be hampered here. So that's another consideration which you will have to take into. The angle kappa and the angle alpha are the two components here. The angle kappa tells you about the IOL decentration. So if the angle kappa is going to be larger than half the optical diameter of the optical zone of the lens, then the central optical zone, then it's not going to be a good patient here. So larger angle kappas, you will have a higher decentration, and the patient's happiness will not, it be an unhappy patient in the postoperative period. The same as in angle alpha, which predicts about the tilt of the IOLs here, and these again are not going to be patients who are going to be happy if you're going to take them. So this in a nutshell is what all you will need to look at in the preoperative evaluation. So I'll just, I think I'm almost out of my time here. So I'm going to conclude in a simple flow chart of what you will have in your OT or in your minds or on your protocols here. So patient selection, please re-emphasize the need for an or an spectacle-free postoperative period in the patient before you're offering the advice of a premium or a presbyopic IOL, and the lifestyle requirements of the patient. Pay particular attention to the nightlife or their day-to-day activities in low light conditions. See if a patient is a perfectionist or a type A personality here. The checklist is the preoperative refractive error, refractive status of the eye, and the visual potential of the particular eye here. So all your premium IOLs perform dot on if the visual potential is going to be 6.6 for these eyes. So when the visual potential is compromised preoperatively because of other ocular comorbidity conditions, then those are eyes in which you're going to be skeptical in adopting to use premium IOLs in these patients. Look at the cornea for regular astigmatism and for lower order aberrations, the pupil size, the angle kappa, and the angle alpha. Most important are patients who have undergone prior refractive surgeries, and these are patients who are sort of resistant to wearing glasses. So that's where you will have to be cautious. Optic nerve disorders, retinal disorders here are other glaucomatous disorders or other conditions where premium IOLs are not going to be suitable for our patients here. Biometry, you could use a variety of biometry. There are a lot of imaging modules here. I think we have advanced ones, which I think you will be hearing more about in your conference in the next 2 days. And do familiarize yourself with what gives you best results in your hands. Another particular component is learning to estimate your surgical induced astigmatism. So each surgeon should have his or her own SIA, and that helps you to tailor or customize your IOL calculations when you're using these premium IOLs as well here. And in premium IOL selection, what you talk about is just monofocal IOLs. You talk about accommodative IOLs with lower or higher near rads, or use the analog multifocality IOLs, or the EDOF IOLs, extended depth of focus IOLs. This is the range which we have with us now, and they perform fantastically well with the provision, provided that you have chosen your patients correctly here. So patient selection is very important here. An ocular feature checklist to look at, you go through all these particular conditions, the corneal conditions in particular here, the biometry imaging, and you should be aware of the kind of formulas and what you need to adopt for which particular IOL you are choosing here, and special attentions to post-surgery patients here. This is an eye trace imaging which shows you about the biometry capture. This is ray tracing here, the angle kappa, and the higher order aberrations, which you are able to get all in one particular patient. I think I have exceeded my time limit, so I have much more to talk to you about. I think it's an endless talk when you talk about how you optimize ocular surfaces, but remember to look at the adnexa, lids, the lid margin, the contact lens, where in those patients the other corneal pathologies other than just dry eye disease, meibomian glands, blepharitis, pterygium, Salzmann's nodular degenerations, and anterior basement corneal dystrophies, where the surfaces will have to be optimized not only by medical therapy, by lubricants, but by other modalities as well. I think I will stop here in the interest of time, and thank you for your patient hearing, and again thank the Jharkhand Ophthalmic Society and Dr. Bharati, for having given me this wonderful opportunity to be part of this particular meeting here. On this note, I will close and I will ask all of you for your kind patronization in considering me for the post for editor IGO. Thank you very much for your patient hearing.
Thank you, madam, for a wonderful scientific talk. And I think all the PGs and everyone, even the practitioners, they have enriched by her talk. So I am just going forward to OT because OT is ready. And the first session is cataract surgery session. And the chairperson's moderator from OT is for the cataract session is Dr. BP Kashyap, Dr. Vibhuti Kashyap, Dr. Sitesh Bargal, Dr. Pooja Kumari, and Dr. Nidhi Gatkar Kashyap. They have done a wonderful job. And chairpersons are Dr. M. Manapi, Dr. Anand Thakur, Dr. Utpala, Dr. S.K. Mitra, Dr. Vibhuti Bhushan, Dr. Rahul Prasad, Dr. Sunil Kumar, Dr. Deepak Lakra, Dr. Sugato Pal. Discussants are for this session Rajiv Ranjan and Dr. Ratnesh. Surgeons, the first surgeon from OT is Dr. BP Kashyap. He is doing Lensex with refractive base EDOF IOL, that is VP. So Dr. Modi, am I audible? Hello?
Hello, good morning. Can you hear us?
Yes, yes, very clearly.
Okay, is the screen visible?
Yes, very much. Dr. Mitra, come here.
So this is a patient, 62-year-old diabetic patient. His right eye will be operated. Best corrected vision is 6/24, NS 2 to 3 with cortical cataract. Planned for VVT with lenses.
Everybody, what is the patient's profile? Dr. Nidhi has just explained. How far the how many times how much time it will require to start the surgery?
So we are ready for the surgery.
Okay, so can you see the patient's eye?
Yes.
Yeah, patient after the dikhaiye. Huh? Okay, so this is the right eye of the patient. First of all, we register the patient. पूरा आंख खुलेगा और ठीक सेंटर में देखिए एक लाल बत्ती जल रहा है. यहाँ देखिए सेंटर में एक लाल बत्ती जल रहा है, उसको देखते रहिएगा. नीचे नहीं देखना है, सिर्फ ऐसे रखिए थोड़ा सा और लाल बत्ती दिख रहा है. लाल बत्ती दिख रहा है. नहीं, लाल बत्ती नहीं दिख रहा. सेंटर में क्या दिख रहा है? लाल बत्तियां है ना, वहीं पर देखना है, इस लाइट को नहीं देखना है. ठीक है, ठीक है, वैसे देखते रहिएगा.
Okay, we are seeing the dots.
Yeah, so this is the registration of the patient is in progress. And now the patient's eye is registered. Now we'll put the PI, that is patient interface. This is the patient interface. We wet the cornea. आंख बंद नहीं कीजिएगा. हाँ, बहुत बढ़िया, ऐसे देखते रहिएगा, एक सेंटर में देखिएगा. हाँ, now we are docking the PI, एक सेंटर में देखते रहिएगा. उसी तरह now you will see the OCT. हिलिएगा नहीं ना, हल्का सा दबाव महसूस होगा. एक सेंटर में देखते रहिएगा. Suction on. Now the suction is, now the lens is holding. Now the machine is holding the patient's eye. And now this is registered. And in the screen, you will see that the cycle rotation is approximately 5 degrees. So we adjust the limbus. The first main incision. And the second incision. Now we check the lens. Lens markings are in the center. The red zone which are saying that's for the capsular axis. And the cut in this case, every pizza cut and the cylindrical cut.
आपको नहीं मैं. Can you hear me?
Yeah.
Can you hear me?
Yes, yes. Go ahead.
I'm Dr. Anil Shah.
Now we scan. On the right hand side of the screen, you will see the axis. This is the delta up and delta down. So this is the center. We accept this. And this is the oscillity of the lens. It shows that there is some amount of focus subcapsular cataract. So we go a little down and set this depth and then accept it. Then we further proceed for the main. Then we accept it. Now we have to verify, accept and verify, accepted it. Now it's ready for the fire for the laser. Ready? So now the rexis is happening. Completed. Now the nucleotomy is happening. The first is rexis. Then is nucleotomy. Nucleotomy is the way you have adjusted, that is pizza and cylinder. And then this is the gas bubbles. And then this is the main incision, which is set to 2.2 millimeters. And this is side port, second incision. Now the part of the lens is finished. The patient is being transferred to the phaco OT. या पर लेजर का काम खत्म हो गया, अभी आपको दूसरे ओटी में जाना है. तो ड्रॉप डालिए. And we are putting the pupil dilator and plus fluor eye drop, so the pupil remains dilated.
Dr. Kasif sir, what do you do with the little uncooperative patients?
In such cases, very well.
Yeah, can you hear me?
Yes, yes, tell me.
What do you do with the little uncooperative patients?
In such cases, we give peribulba very little amount, because If you give more, there will be chemosis, and the machine will fail to take the registration at the time of operation, that is during the phacoemulsification by Centurion. Normally the patients, they cooperate, especially if the patient is with the for the toric IOL, you have to be very, very careful. There should not be any kind of a hemorrhage, or there should not be any kind of a hemosis, because the variant will fail to change recognize the axis. ड्रॉप डालिए फिर से.
Madam, people were asking.
Okay.
Hi, Dr. Kashyap. For them to see it? Yeah,
Yeah.
it's there on the screen. Hi, Dr. Kashyap.
Hi.
Good morning. This is Dr. Vanati here.
Hi, Dr. Varanthi.
Hi. I think the difficulty when we are docking on patients where there are small eyes is something, is only the problem which we envisage nowadays. And I think our patients do cooperate very well when we are docking for the laser cut using Lensex. Any particular difficulties you have experienced, sir?
If the most important part for the Lensex or the laser cataract surgery is the pupillary diameter, if the pupil is not dilating, you will not be able to do a proper rhexis.
Yes, that's correct. And do you modify the rhexis size in these cases, or would you optimally keep it like 4.9 every time?
No, I generally keep it at 5 and then can modify according to the need of the patient. If suppose if the pupil dilates, let's say 6.5 millimeters only, in that case you can further reduce the rhexis size.
And do you vary your energy settings every time, sir, according to the grade and the density of the cataract, or you go with standard settings?
We do that, but then we already have made up our own settings, right? You know, in a hard cataract, let's say moderate hard cataract, the very, very hard cataract, grade 5 cataract, we have made those settings. So every time I don't have to do it, but then let's say if I find that there is a capsular thickening, in such cases for rhexis, we increase the millijoules. We increase the strength of the power of the laser.
Okay. And the pattern which you use for your nucleotomies, your laser nucleotomies, is it standard with the 8 cut, or you would go for combinations with the cylinder patterns and with 8 cuts, 4 cuts, 6 cuts?
I generally go for the pizza cuts, but if it is a case of a posterior capsular cataract, in such cases, it's a cylinder cuts.
Okay. Thank you so much, sir, for clarifying. I think now we could go on and watch your surgery as well.
Yeah. Now we'll be starting the OT2, in which we have got a SICS, and then after that you will see this surgery.
Hello? Hello? Sir, can you hear me? Hello, am I audible?
Yeah, you are audible. Go on.
Good morning, sir. So we are live from OT2, and here we have a case of 64-year-old female who is being planned for left eye small incision cataract surgery, and sir is going to show the snare technique also. The grade of the cataract is NS3 to 4, and we have planned Swiss Fob IOL 21.50 diopter. Over to you, sir.
Good morning, everybody. I'm Dr. Anil Shah, Suryakanta Hospital. I'm thankful to Kashyap Hospital, Dr. Kashyap Madam, and all the Jharkhand Ophthalmological Society for giving me this opportunity to show snare technique for small incision cataract surgery. Snare is a wonderful instrument which can be used to divide any grade of cataract. Before starting the surgery, I will show you how the snare is there and how it works, so that it will be very easy when you watch the surgery. Show me the snare. One snare. One snare. See, this is the snare which I have designed.
Can we have the microscope?
This is
Microscope, sir. Hi, Dr. Anil. This is Dr. Vanati here. The entire audience
this
here.
is a low magnification. I will be showing you the snare. This is a handle of the snare. This is a handle of the snare, and this is the body of the snare. And there are two side holes at the tip of the snare.
The microscope to focus on the region of interest, because we are having a broader view. We are not able to see it.
This is a loop, and which is coming out to the small incision, small holes, and the loop can be rotated, and you can make it smaller or larger.
Please, Pooja, can you hear us?
माइक्रोस्कोप का
हाँ.
वीडियो शेयर कीजिए.
Hi, Pooja, can you hear us? We are not having the microscope view. We are having the surgeon view. Yes, it's coming into focus. Yes. Can we
Can you see now?
again? Yeah. Can we see the snare again, sir?
Yes.
Everybody wants to see the snare because everybody is getting fascinated how you do with such a small incision with the snare. So Dr. Pooja, the OP coordinator too, please
Yes, ma'am.
show the snare for microscope. Everybody wants to see that. You know,
Can you see the snare?
everybody wants.
Can you see the snare?
Yeah.
Yes, the miraculous snare everybody has seen.
This is the body of the snare, and this is the handle of the snare.
और फोकस करिए, थोड़ा थोड़ा मैग्निफिकेशन कम करिए.
कम किया है, कम किया है,
आएगा पूजा.
कम किया है, मैग्निफिकेशन कम किया है.
Yes, ma'am. Yes, see.
और ये लूप है स्नेयर का.
अरे स्नेयर का बॉडी भी दिखाओ.
Can you see this loop?
अरे this is the end piece. We can see. Pooja, please reduce the magnification. We want to see the entire snare.
Okay, ma'am.
ये
Okay,
नहीं,
ma'am.
reduce किया ना. ये increase हो गया. तो लो किया मैंने.
हो गया. I think
Increase कर दिया तुमने.
if you can just
काम करो.
if you can decrease the
हाँ.
we just want an entire
पीछे करो.
Can you see the other loop magnification now?
हाँ ठीक है. तो आप ऊपर वाला पार्ट दिखाइए.
हाँ.
हैंडल.
हाँ.
पूरा हैंडल दिखाइए. और नीडल दिखाइए. नीडल.
Ma'am, this is the least magnification.
This is
Actually.
the least magnification.
I think
2.4 magnification.
move the snare across so that
Here the snare can be rotated, then it can be pulled and pushed with the handle, and the rotation is also possible with this needle. So intraocular manipulation is very easy. You can divide any grade of nucleus into 2 pieces or 3 pieces. That is the beauty of this snare. Is it okay?
And please show the hand piece. Yes, see needle में है. Needle में है.
Dr. Shah, hi, Dr. Mitra this side. What is the difference between the snare of the Disha Eye Hospital was using earlier?
Disha Eye Hospital is already using my snare. I had been to Disha Eye Hospital in 2002 to demonstrate the surgery, and after that they are using the same snare which I have designed. They are using my snare only.
But handle seems to be some slight difference in between.
That is my made homemade. This you can make it at your home also. So this is a homemade snare. It is do it yourself. You can make it also. So this is the snare which I am going to use it. Is it okay?
Is the microscope view visible?
It's visible.
Okay, sir.
बराबर है क्या? ठीक, just वो जो focusing है ना, वो ये मेरा पैर बराबर है focusing का. Already made a transconjunctival tunnel incision. Now, with the crescent bed, I'll be enlarging the incision.
The size of incision you have already made. What is the size of incision you have already made?
This 3.5 millimeters.
It's a 3.5 mm incision. We're doing tunneling. Result is using it.
Madam, don't worry.
Concentrating on that. Yeah.
Which microscope you are using?
This is upper soil microscope.
Very good glow.
Advanced. Upper soil advanced.
Good morning, Dr. Anil Shah, sir. So you're making transconjunctival incision, and how much away from the limbus is this, sir?
It is almost 1 millimeter or less than that.
Okay.
Excellent.
He's not made a flap.
So the external wound is 3.5 millimeter, and what will be the dimension of internal wound, sir?
Internal is almost 5.5. No, that is sodium hyaluronate.
Yes, sir.
Sodium hyaluronate. Now I am using sodium hyaluronate in all these type of snare cases so that it is very comfortable.
So you do not want to stain your anterior capsule routinely, sir?
I stain it if it is grade 4 and the visibility is poor.
Have a good glow, you prefer to go directly as well. Any particular recommendations for the rexis size you would like to have, sir?
Rexis actually 5.5 millimeter is good.
And so I think this is a topical surgery, sir.
No, it is peribulbar.
The peribulbar here, and I think the assistant you would not prefer to have your cornea wetted in between, or would you like to have viscoelastic over the cornea? So here we are watching a needle cystitome assisted capsulorhexis. Any words of wisdom from the panel on preferences for their instrumentation for capsulorhexis?
Rexis is a little smaller. I would enlarge it.
What do you do, Dr. Vanathy? You use cystitome only, or you use forceps to do your excess?
In the cystitome, sir. Yes, sir.
Yes, I also commonly use the cystitome in most of my cases.
Now here I will delineate the wound so that premature entry doesn't occur. With the visco, we demarcate the inner lip.
Only in intuition catheter. No, which I put. That's one. If I have value, it doesn't leak. Because we give maintenance.
This is my different hydrodecision cannula. It has got a tip facing downward. It is connected to the IV set. So the fluid wave is in. I try to make the very smallest nucleus possible. I try to do hydrodelineation with the same cannula, with the pole as prolapse. Sodium.
Dr. Bhanu, you change your capsule on cases? You change your capsule in all cases?
I do stain my capsule in almost most cases here. So it's become sort of a routine protocol when we are doing our phaco surgeries here. And I always do prefer using a needle cystitome for my capsulorhexis. Only in the event of an extension, either in an intumescent or a white cataract, do I resort to using a intravitreal forceps or scissors to manipulate the way the rhexis is moving around here. So one particular query to me, because I do not use the snare, do you alter your rhexis size depending upon the size of the nucleus in most of these cases? So any particular descriptions for the benefit of our audience?
The nucleus is brought into the anterior chamber. Now I am using this sodium halo below and also above, making the nucleus free floating snare. Now I'll divide the nucleus into two pieces by snare. I will make the loop slightly smaller, go obliquely below, and then divide the nucleus into. If you want, you can make another piece also. I'll show you trisection also.
You please do it slowly because it looks so smooth and so fast.
I will do trisection. Actually, it's not needed, but for the demonstration, I'll be showing you trisection also.
So if you make the piece still smaller, maybe you may be able to decrease the incision size lesser than 3.5, sir. Have you tried that? He's done it. You've answered my question by showing it how to do it, sir.
Yes, sir. Now these are the three fragments which are separated: McPherson forceps, white one. Now this is a simple McPherson forceps. Older McPherson is a better grip, so I use this old McPherson.
So you have manipulated the McPherson.
One nucleus is taken out. Now separate these two nucleus again. There is no pressure, no tension, nothing is to the endothelium or nothing to the wound also. There is no force required.
Sir, I am Dr. A.K. Thakur here. My question is, here the nucleus is very transparent. You can see the posterior loop also of the snare.
Yes.
There are cases where the nucleus is very dense and opaque, and you cannot see so well the posterior loop of the snare.
Yeah, yes, yes.
In that case, how safe you feel yourself to use the snare?
There is no problem, sir. I have never ruptured any PC in last 25 years, sir. And never caused patch addis also, sir.
And what about endothelial touch?
Endothelium touch, you have to be cautious that time. Loop should not be bigger, loop should be a smaller size. Continue. Irrigation.
Sir, I have a question, Dr. Vivek here. Which viscoelastic would you advise us to use for these surgeries? Just normal HPMC or anything above that, Helon or chondroitin sulfate, what would you advise?
Sodium hyaluronate I usually advise, sir, in this type of patient for initial purpose. So this is another new change in the aspiration cannula. See, my aspiration cannula is has a tip facing laterally. It is not on the front. It is facing laterally. So lateral aspiration has got many advantages over front aspiration.
So just two things I want to clarify. One is your exercise should be 5.5 at least. And then the
5 millimeters also okay, sir. Depending on the size of the nucleus. If it is smaller, no problem.
and why you are not using AC maintainer?
I like this bimanual, sir, so I'm not using AC maintenance.
No, during
See, this lateral aspiration port is very easy. You can go below the capsular rim and aspirate. I will do interchange.
You have modified all your instruments, sir. Please show the person also which you had modified to remove the nucleus pieces.
Sir, going back little with your hydrodissection, you have put it into the IV drip. I'm sorry, to the drip set. And what's the advantage you are getting by doing hydrodissection that way?
What, sir?
Your hydrodissection, continuous fluid infusion rather than the classical way of doing hydrodissection. What's the advantage you are getting by doing that?
Oh. 1 minute, sir. The page.
Sir, can snare be used in Blumenthal technique also?
1 minute, 1 minute. 1 minute, let me complete this. I'll
I'm asking, can snare be used in Blumenthal technique also?
No.
Okay.
Snare cannot be used in fluid. Snare has to be used in viscous only.
Okay, thank you, sir.
हाँ हो गया मैडम एकदम अच्छा हो गया बहुत अच्छा है आपको कोई टेंशन नहीं लेनी अभी this is the Swiss scope lens which I am implanting. This is a new lens from Appa Swami. It is similar to IHANS or better than that, as they say. So this is their cartridge. So their cartridge.
Which
Sir, can you-
upper.
Okay. Dr. Pooja, can you, or sir, can you tell us more details about the lens which you're going to be putting in?
हाँ हाँ 2 मिनट में हो जाएगा.
Can you hear me?
Yes, yes, we can hear you, Pooja.
Yes, ma'am. This is a hydrophobic single-piece foldable IOL, which is by Appasamy Associates, and it's a Swiss phobe enhanced vision IOL.
Okay.
It's aspheric optics and 360-degree square-edged intermediate vision optics.
Okay. This is a hydrophilic or a hydrophobic lens?
Hydrophobic, sir.
Hydrophobic.
हाँ ये पूरा था. हाँ. आपका मास्क भी निकल रहा है. नहीं नहीं नहीं, आपका मास्क निकाल लिया. ओके मास्क मास्क नीचे injector system is also similar to that.
Hi, Dr. Anil. How is the ease of insertion with this lens? And any particular concerns you have when you're loading and inserting in this IOL model?
क्या करूं? ऊपर करिए. बराबर है. मेरा भाई 2 मिनट में हो जाएगा.
कोई बात नहीं. मतलब मुझे सांस लेने में कोई दिक्कत नहीं है. मुझे बहुत अच्छा लगता है. आप अपना काम कीजिए. ऐसे बनाइए कि यार मैं दुनिया की
जो मैडम एक बहुत
कोई बात नहीं है.
Dr. Vanati, ma'am.
Yeah, small here.
Ma'am, we have just started our DNB training program, surgical training. So they have begun with SICS. I want to know whether the beginners should do SICS from side port. They use 62. So it is preferable for them for the Rexus or main port. I would like your view on that.
I normally put small air bubble.
We might also ask some.
I don't do side port hydration.
So when you're starting your surgical training, it's best to do stepwise in the structured surgical training.
Dilute करो, dilute. Dilute.
Perfect. And then go to the next step here. Okay. And when you're doing a cystoscopy, a full fluid filled chamber always helps you in good control of your access.
Dilute.
Doing to the main course,
नहीं हुआ ना, थोड़ा और dilute. Concentrate नहीं है उस पर.
you want to control your capsular access. So then it is better to do, you can have your main port form, so then use it for your health when you have to insert a larger.
This is Vigamox.
This is because we didn't want to disturb him. That's why I'm purposefully flipping. This is for the. So
Hydration.
when you're learning your little tank, so the posterior lip of your incision. So when you're pressurizing the posterior lip, you still will not optimally learn to control your axis movement. So when you're learning, you can have your main wound formed, a compact, a good wound architecture, do from your side port so that you do not lose your chamber throughout when you're learning. And after your 10, 15, 20 cases, you know to calibrate or titrate the pressure you're putting inside. After which it really doesn't matter because you're going to use the same one and you will not be pressurizing your posterior lip when you're doing this. All that the initial point of view, so many things to learn, it becomes difficult in this generation.
Can you see me?
Hello, we are back to OT3 to start the Lensex case, which was done earlier. Now the paper multiplication of that case will be done by Dr. BP Kashyap.
Doctor, you are talking about the first case which you have seen.
No, this is the first case whose Lensex was done, and now the paper multiplication will be done.
Yeah, okay.
So the patient is under topical. So that's one important thing when you are doing flax surgeries, you will have to assess the comfort of the patient under topical anesthesia. So the patient needs to fix onto the lights, and that's imperative for a good capsular access and for making optimal nucleotomy so that and it does not move when the razor is firing. And again, as you can see, the sir is now starting the surgery and the registration system, and which is marking on. So it's a markerless online image guided system for a toric IOL implantation, and in which flax has been used to do the nucleotomy.
So we have stained the corner incision, main incision, and side port. I will try to open it.
So do you modify your main incision and your side incision sides by moving it a little anteriorly in your flax cases where you have a pannus or you have vascularization coming in?
Yeah, I can. Right. So we have opened the main incision.
Yes.
And putting the viscoplastic in the anterior chamber. Can you feel it?
Yes, sir, we can see you. So, sir is now has opened up the main incisions. I'm not able to make out, sir. Have you opened the side incisions as well?
No. We have just opened the main incision. They are cleaning the optics of the microscope because there is a splash of water. Yeah. So you have a free floating rexus.
Because the patient interface in the line with the suction, it does cause a ring of hemorrhages and tissues. More in hypertensive patients, it is quite scary. If you could find a higher percentage to reserve this or routine treatment. Only thing the patient complains is.
There is a rexus. Enter capsule, remove. Then we are going to open the side port. Beautiful machine. I think Lensex is the best machine for the corner incision. And then what you can see, the yellow kind of a reflex is they are all air. So when you're doing the Lensex, it cuts the lens and then the air bubble is generated which goes behind the lens. So you have to remove this lens, these air bubbles. You see the air is coming. Little more of visco. Dialer.
So these are the some of the variations when we are doing flax here. We open up the main incision first. So dry the incision and then open it up. And the modifications would be that when we have peripheral opacifications, like in cases of prominent arcus or pannus, you will have to manipulate the positioning of your main and side incisions after opening up the incision.
For the benefit of everybody, let me tell you that whenever you start with surgery, phacoemulsification, you must see to it that this flow of the fluid should be enough from both the sides and should be good.
Yes.
You cannot make a one line. There should be two flanks.
Then we go in and check that the capsulorhexis cut is optimally made. Gently take out the capsulorhexis. And most surgeons prefer not to do a hydro procedures here. Do a gentle tap to release the air which is trapped behind. And some surgeons, and I also do, release air and do a minimal hydrodissection procedure before I continue with the phacoemulsification. And sir is now trying to divide the nucleus along the laser cuts which have already been made earlier with the Lensex. So the particular learning curve here will be to the depth at which you would like to impale your phaco probe and use your second instrument to divide exactly in the vicinity or in the region where the cut has been made. So once you are in the right plane, you would find that the nucleus divides like a piece of cake out into several pies as per the division pattern which you have used earlier in your laser cuts.
So what is the exposure of the tip, phaco tip in case of a hard cataract? In case of hard cataract, are you expose it little more than the normal grade 3 or grade 4?
Yes, Dr. Mitra, who will know better than you. You are the expert in hard cataract. So you have to expose more.
Yeah, we could see the crack.
Is there another pie?
Yeah, the trick of getting the bigger chunk, you have to catch the end of the chunk, is it?
Yeah, you are right.
Like कान पकड़ के बाहर निकालना.
कान पकड़ के, हाँ सही बात.
Dr. Anisha, any query you can. Dr. Subodh call. Next number आपका आएगा. अभी नहीं अभी. We don't want.
Sometimes these nipples they play very naughty. You have to make them straight. And routinely I take out my side pot if I'm eating the last chunk.
So we usually take out the side foot when you get
The nucleus is removed.
do like this. So when we are in emulsifying the epinucleus and when we are in the epinucleus mode, we take out the side port just to keep the AC maintained. It is safer also. So how many of you do it?
Now I initially do not make two side ports, but if I find any difficulty or if I see that the anterior chamber is not fully maintained, then I make another incision here. So initially it is not done. If there is any problem, I'll do that. This is the aspiration mode. Take out the cortical matter. So no cataract surgery is finished before the eye is closed. So you have to be very, very careful in each and every step. कौन है पर सलाइन दीजिए जरा सा. I change my hands now. Irrigation on the right and a suction on the left. So this is clean now. Then I put a gush of fluid to remove any kind of a lens fibers. Put a little bit of visco. I know a lot of people are not using viscoelastic for before putting the IL. I do not prefer that, because for that the incision has to be a little bigger so that the lens goes inside properly. Is it clear? I load the lens myself. There is a Vivinex. Sorry, I'm sorry, VBT. So the lens has to fold. You have to fold there, go inside, and then I fold it here. पालती मार के बैठा देते हैं. And that's it. You see that the lens is moving freely. Yeah, so it's good.
Sir, you load the lenses yourself or your assistant will do it?
I load the lens myself because I know how the lens will behave. थोड़ा सा दबाव महसूस होगा, हिलिएगा नहीं.
Yeah, better to load by yourself, and it should be under microscope.
You are absolutely correct, Dr. Mitra. You're the boss. So nowadays I've started putting the haptics in the horizontal position to avoid all those scotomas and other aberrations.
So we have witnessed a very meticulous surgery here. One question to you, Kashyap sir, that
Yes, sir.
do you sometimes, so we have seen it being put under viscoelastic. Do you sometimes prefer to implant the IOL under fluid?
You tell me, Abhijit, if you want to put the IOL with the help of fluid, the lens and the cartridge has to enter the wound properly. Our incision is 2 millimeters, or at the max sometimes 2.2 millimeters. So you have to put a lot of pressure there at the incision. At the moment you put a lot of pressure at the incision, what happens is the other wound starts leaking, the other incision. So ultimately you land them in a shallow AC, and then sometimes you have with the jerk you do whatever, a lot of complications. So it was a beautiful surgery, and before I end, I stop my irrigation, do a little bit of massage here, start the irrigation, stop it, do a little bit of massage here, start the irrigation, and then with the support I close this so that the anterior chamber remains maintained, and my assistant is ready with the hydration of the corneal wound. So thank you very much for observing my case. And I always remove the speculum under the microscope to see that everything is fine even after the removal of the speculum. Now in this case, So in this case, after the removal of the speculum, you can see a little bit of fold here. So again, I inject some amount of fluid, and it becomes tight and fantastic. बहुत सुंदर हो गया ऑपरेशन आपका. आंख बंद कीजिए, नाश्ता पानी कर लीजिएगा.
You are a very meticulous surgeon.
Thank you, Abhijit. It is all love talking. Your love towards me is talking. Thank you, Alkan. It's a very nice microscope. Very good one. The Luxor Revalia.
Thank you, Dr. Kashyap, for the wonderful surgery. So, Dr. Nidhi, the OT coordinator 3, can you hear me? Dr. Nidhi?
Yes.
So,
Dr.
Dr. Nateen here. Dr. Nidhi is also here.
okay, so the third surgeon is Dr. Bhasin.
No. Now we will be having a supraforay by Dr. BP Kashyap. By then, Dr. Basin's limiting is willing. Our next case is a supraforay by Dr. BP Kashyap.
So, after Dr. BP Kashyap, Dr. Bhasin will be doing VVT toric, right?
In VVT, not.
And after that, Dr. Sugatopal will go to OT, right?
Ma'am, you can send Dr. Sugato after some time. By the time first patient, he will start retina, ERM.
Okay. So, Dr. Sugatopal, you can relax here. You can be a discussant because they will start a retina OT also. So, they are coordinating between among the 4 OTs.
Are we live?
ये बाकी सबका वो ऑफ कर दीजिए, म्यूट कर दीजिए और इनका ऑन कर दीजिए.
Hello, ma'am. Hello.
Yes, Dr. Nidhi, boliye.
By the time patient is getting set up, if there are any questions, sir can answer. Dr. BP Kashyap.
Acha. So,
While cutting the drape, you have to be very, very careful. And then you should not cut any part of the skin of the patient because it starts bleeding and then you are in a mess and the patient asks why there is a redness.
so faculties who are here, present here. So, how many of you use Indian toric also? Because many a times our patients don't have that much of economic status and they want a cheaper lens. So, Dr. Vivek Kedia and Dr. Rajiv Ranjan, they often use Indian toric. So, APPA has come with an Indian toric, suprafope toric, and there are all other Indian companies also which have come up with the Indian toric. So, you have any experience with the Indian toric, Dr. Bhalla, Dr. Manish?
Bharti,
Any experience, sir?
I have got a question for Dr. Kashyap.
हाँ
I have got a question for Dr.
हाँ
Kashyap.
बोलिए.
You want
तो एक बार सर एक बार पूछ लेते हैं लोग सर. आप लोगों ने any one of you have a experience with Indian toric? अच्छा, आपा का toric use किया है? कोई भी Indian toric? So, what is your experience?
This case is marked for the excess in the varion, and this patient is brought here for Japan blue. This case is very, very hard cataract because of the good retro illumination by the upper semi microscope. It's looking, a very not so hard cataract. So you can see the mark here. You can see the mark here. These are marked by the.
we cannot see you.
The video is not visible.
Yeah, Munna ji.
Your
we are not
video is
seeing you.
actually not visible right now at the hall. Yeah, now we can see it. I have used 2 companies, toric IOLs, 2 Indian companies, and the experience has been good during one particular case wherein I don't know when I was placing it at the axis, it was by itself rotating by about 7 to 8 degrees. Even after trying for almost 10-12 minutes, I could just not place it at the axis where I wanted. Maybe in that one particular case, I had a bit of rhexis runoff. At one particular point, my rhexis had gone beyond the optic margin. So I assume that was the reason why I could not get the stability in that case. But again, that's no assumption. I don't know if there was any other reason for that. Other than that, I've had a good experience. I used biotech as well as there's a new company, AdTech, which I'm using right now. And with AdTech, a peace of mind is that they always provide with an extra lens of the same specifications. So that peace of mind that if anything goes wrong with at least one case, you always have a backup
Okay.
that lens.
Air and the sun.
Hello, sir. This is Dr. Anindya. So as Dr. Vivek said, I do the same. I keep always extra lens in hand. Just if anything goes wrong, I keep on trying for, yes, I have tried for Indian lens. I don't want to name. There was one lens that haptic was broken. After that, I didn't use that. But still far, I can say I use Oro more frequently, and I find Oro more stable in comparison to other Indian lenses. I believe I have used more than 20 plus Oro torics, so they all do good. None of them, they have yet caused any problem.
Of the two companies that I have used, the main difference has been in the shape of the haptics that I saw. The biotech lenses, they have a C-loop haptic, and the AdTech has a serrated haptic on the outside, on the outer margin. So theoretically, it gives a more stable placement of the lens that I have seen in my experience.
For the benefit of the delegates and all who are attending the conference, it is already on the net. The live surgery is going on the net. This is the first time in Jharkhand Ophthalmological Society is over the world. I mean, they are telecasting.
It's all Dr. Mitra, Dr. Bharti, they have worked very, very hard. To tell you very frankly, they did not let me work anything, you know. अरे हो जाएगा, आप थोड़ा सा एज हो गया, आपको ज्यादा आराम कीजिए. I said, I'm young, still young. They will not let me do anything. So they have done everything themselves.
Kashyap sir, I have a question. Which method do you employ to mark the axis of incision before beginning the surgery?
I do my 100% cases under Varion. Since the Varion is busy in the other OT, so I have with the Varion I have marked the axis here and brought the patient to the other OT.
Sir, but we poor souls don't have access to Varion. So for people like us who don't have Varion, what would you advise? So the bubble marker or
So the other best thing is the air bubble marker.
Okay.
But it is very easily said and done, because you know when you look at the one side of the bubble, the other side is not visible. So you have to be very, very careful. बहुत ध्यान से देखना पड़ता है. Purposely I have made this rhexis bigger. Side port. I sit at 12 o'clock position. Make incision normally at 35 degree and 150 degree. I'm so used to this incision so that if I have to see whether the machine is working or not working, I give my incision and see whether it is corresponding to about 35 degree and 150 degree. This is a very, very hard cataract. So I'll use my Phaco 2, that is for hard cataract. And patient is, she has got kyphosis. A lot of arcus senalis. Chopper देना, give me a chopper, give me Phaco 2. Phaco 2 setting.
So does the site of side port incision have any bearing on the overall result when we do torics, should we always aim for putting it perpendicular to the main incision, or as you said, it's based on what the surgeon is more comfortable with?
Yeah. Did you ask something, Dr. Vivek?
That's a side port incision, the placement of the incision, side ports. Does it have any bearing on the result of the surgery? Should
Yeah, you can have a overlock. You can have, if you go more horizontal, there are a lot of problems. So you put it, for every surgeon to his own.
Yeah.
Yeah, exposure. On hard carpet, I do a bulking.
Hello. Actually, initially when I started as a using torics, initial few two lenses initially, I did have some problem that with the fear, probably that was a beginner's fear, that with the fear that probably there will be some rotation. I kept it a little behind the markings. So, and afterwards, I did have the same amount of astigmatism. I had to re-rotate the toric lenses, but afterwards, almost I have put 14 to 15 Indian torics, and the result is reasonably good. As far as definitely there is, even if I'm left out with 0.5 or 0.25 kind of astigmatism, I'm still happy at present. Thank you.
Hello, I am Dr. Rajiv. I have used Indian torics, mainly of iCream company and Apasami, and results were good. Of course, it did not came to absolute zero, but it was about 0.5 cylindrical or 0.25, but it was acceptable, and patient was happy. The main important thing is the marking of the patient. It should be done in the sitting position, and because some degree of rotation is always there when the patient lies down. So the marking is more important in the under slit lamp. It should be done very properly. It's some videos are there in Arvind Eye Hospital.
Patella crack technique, in the center is the hard nucleus. So this is patella, crack the patella. It makes your life very easy.
I think one of the main concern about Indian toric or Indian hydrophobic IOL is the cartridge. I have had torn haptics few times with the butterfly cartridge. If your assistant is loading, we have to make sure the lens is moving quite well. With the Alcon toric, the cartridge system is such, even if you try, the lens will not get caught most of the time. But with Indian toric, that is one concern, is the lens loading and clearing the haptic. Otherwise, I do a lot of Indian toric, results are excellent. I do use care group toric mostly, and also iCril and Oro.
Pheco one. So in hard cataract, and the last bit I'm taking, I go to Pheco one, and there is softer cataract, and then remove the side port.
I totally agree. I think Indian torics are as good. Let us have this concept. It's the proper marking, proper pre-operative assessment. They are good. It's only that, like Dr. Sugato said, what needs to be improved, needs improvement is the cartridge and the injector system. Lenses are as good, they are as stable.
You see the last piece, they are the very naughty piece. It had gone behind the iris. So you have to be very, very careful. So
Dr. Kashyap, what is the chopper you are using? I found that it was about 1.5 millimeter tip and it was a sharp chopper.
yeah, it was sharp chopper. I use that only in cases of very hard cataract.
Okay.
Otherwise, I use Senski hook. IA. Please hold this. IA. Got it.
IOP, you are using 74 epinucleus mode, or is it segment removal mode?
I don't know. क्या बता दो?
IOP.
IOP बताइए.
So okay.
Give me side port. I'll make another incision in this case for bimanual. अरे बच्चा. Sometimes the machine doesn't work properly. Sometimes it doesn't hold. Sometimes it doesn't do the suction. So you have to know whether your technique is bad or the machine is bad. And that comes with the experience. कोने पे सलाइन दीजिए. You see, it has become jammed. Now it's released.
It is on YouTube and it's very, very clear.
Acha, okay. You're on both the sides.
think for beginners, those who are just passing out and starting their own practice, I think two things are important when it comes to doing torics. First is counseling the patients, making the patient understand that why a toric lens is better suited for them. And if it's possible to tell them that, see, this is what vision you get if you don't get a toric, and this is what you get when you get a toric lens. I think that helps in counseling the patient and making them agree for a toric lens. Otherwise, it's a bit difficult because the cost factor always comes into play. And the second thing for beginners is probably apprehension, because during our post-graduation, we probably don't get exposure to doing cases, sensi. So that apprehension probably goes off after 2 or 3 cases, and you have to take that leap. And once you start doing that, once 2 or 3 of your lenses are at a good position and you see the satisfaction in the eyes of the patient, that's what gives you the confidence and makes it easier for you to counsel the next patient who probably needs a topical implantation.
You have done the nucleus management. Now putting a little bit of viscoelastic, and I'll increase the incision slightly. I find the upper toric aisle to be fantastic.
So how much
problem
now at the moment? 3.5. No, you are increasing the incision to 3.5.
Yeah, I start with 2.2 or 2 and then increase it to 2.5. I don't know. To technically go.
So that's the lens they are showing. This is toric lenses.
Yeah, this is a toric lens. The fantastic upper toric IR. अरे बहुत बढ़िया लेंस है सर. ठीक है. So I don't load this lens. I use load only Alcon lenses. हाँ, इसको बाहर निकल गया.
We plan the whole thing in such a way that it includes all segments of surgeries. Because if you show only and only premium Alcon, it will not serve the purpose of everyone, especially the ophthalmologists who go for the Indian or opt for the Indian IOL, and the PG students when they will start their surgeries. So they should have option open कि ये सब भी है और बहुत अच्छा है. So Indian toric आपने तुमने सुना और सर लगा रहे हैं. पूनम मैडम का एक्सपीरियंस सुना, विवेक केडिया का एक्सपीरियंस, अनिंद्या अनुराधा मैडम का सुना, तो इट्स गुड.
One tip of using the toric or any Indian lens, you can use Johnson & Johnson or Alcon cartridge. In each and every cases that goes very, very smoothly. So just change over to the cartridge, nothing else. And the main problem now I am facing, if one eye I have given the toric to the patient wants the same toric in the other eye also. If he doesn't have toric, he only insists, sir, हमको तो एक आंख में toric लगा, इसमें भी toric लगाना ही है. How to counsel them, I don't know.
बोलो कलिस्ता को बोलो कर देंगे 1 मिनट के लिए.
I'm talking about a patient who who has astigmatism in one eye, other is not that much. So if the patient insists कि हमको तो एक आंख में toric लगा है, तो उसमें भी लगाना ही है ना.
For the benefit of the beginner surgeons, as you rightly said, that people are apprehensive or not oriented towards the when to use a toric IOL, which all we also did when these started coming in. Whenever you're looking at your biometry chart, don't right away focus on what is the IOL but focus on the delta K of the patient. By delta K, I mean what is the astigmatism the patient is having. So the first thing you would look on the chart is the reliability of the recording. Then second, you would look at the K1 and K2 and the delta K. Now, most of the latest or the newer IOL biometry, whatever devices you have, also incorporate true K, meaning they also consider posterior corneal astigmatism in it as well. So look at the delta K. When your delta K is higher than 0.7, and if it is against the rule astigmatism in an elderly patient, that is when you're probably going to consider the use of toric IOL in these cases. If you're using monofocal, you can have a 1.2. But if you're using multifocals or trifocals here, then even a 0.8 is something which is not going to be acceptable in the postoperative period, and you will add a toric component. So when you explain this and show these to your patients while counseling, it gives you a better acceptance level. Again, when affordability is a question, then you offer surface astigmatic keratotomies for these patients where you want to use it, arcuate or a limbal keratotomies. But again, I am not a strong patronizer of using surface arcuate keratotomies when you're doing trifocal or multifocals, because that can make your surface irregular It is unpredictable and the patient usually is not happy. It is quite okay if you're combining it with monofocal IOLs here, but not with your multi or trifocals or your EDOF. Lower quantums, yes, they might be helpful. And again, all these arcuate and LRIs work well in your first 6 months postoperative period. And you will find when these patients come back to you, 1.5 years later, the astigmatism eventually comes back. So looking at the delta K, looking at the quantum of the delta K, looking at the against the rule astigmatism in these patients, the monofocality versus the multifocality or trifocality makes a big difference in helping you to counsel your patients optimally.
Yeah, very rightly said. Same is my observation.
So while putting the toric IOL, you have to put the IOL and rotate it little shy of the actual position.
So you have seen the nice implantation, the trailing haptics here. Just hold on to place the lens in the position.
Hello. These are the marking of the toric IOL. So this is the placement. This is the toric marking. Now I go ahead with the irrigation aspiration. Go behind the IOL. Now you can see that the marking is matching the corner parts.
So the trick is you have to hold the lens with the irrigation aspiration cannula. We just push the lens, tap the lens so that the viscoelastics comes out.
Yeah, you're right. And then locally I put here before I come out for the toric IOL. It's further pushes and on the capsular bag.
Mobile phone is on there inside the OT.
Like said by Dr. Mitra, it is important to take out the viscoelastic from behind the lens. One, it will help in the stability. Otherwise, the lens may rotate post-operatively. And secondly, there are also chances of inflammation post-operatively, and the effective lens position is altered. And also, theoretically, there are chances of capsular blockage syndrome because the IOL optic is pushed anteriorly adjacent to the anterior capsule, and the retained viscoelastic may cause capsular blockage syndrome, which can lead to a lot of problems later on. Dr. Vanity, what are your comments on this?
Absolutely correct. So we are done with this case. Thank you very much. It was a hard cat.
Very nice surgery.
Very nicely done, sir. Thank you for the wonderful demonstration. And getting back to Dr. Balla's question is one important concern when viscoelastic is not completely removed or when it gets trapped behind your IOL on a smaller rexis is the postoperative refractive surprise you have. So you will have all your calculations and everything would have been optimal, but you will find that postoperatively your patient is very unhappy because of the refractive index of the viscoelastic which is trapped behind, and you will get an increased refractive error in the postoperative period.
It's called tackiness of the lens material. Actually, the lens material tackiness is the most important thing which attach the posterior capsule attached to the lens post behind. So the tackiness of the lens material, it's better in case of these premium company lenses like Johnson and Johnson, and then Alcon. Johnson technique platform. There's no I think that's the best tacky lenses which I am using ever. So with no financial interest, I can tell you that Technis platform is the most tacky lens in so much. So
To my mind, all the big companies or all the MNCs, they come up with a lot of promises, but a lot of things we have to take with a pinch of salt, right? And our Indian companies are no less, they are also doing fantastic. And as for the removal of the viscoelastic,
Hello? Can you hear us from OT3?
Yeah. Can you see me? See the case?
Hello? Hello?
You are audible, Nidhi. You are audible.
Okay.
Can you see the case microscope of the new case?
Sir, is the microscope visible downstairs?
Auditorium, can you visualize the case? Can you see the case? Can you hear me?
The microscope view.
You are able to see the microscope view?
Yes, Dr. Purendra, we can see the microscope view. Can you?
I am Dr. Purendra Bhasin, and this is the wonderful OT of Dr. Kashyap and their family, Kashyap Eye Hospital. I am really happy to see this. I'm coating the surface of the cornea with the viscoelastic. Now, this is a case of 40 years old female who has a nuclear sclerosis grade 2 with posterior subcapsular cataract. And she is diabetic and hypertensive, but the pupil here is very well dilated. Madam, सामने 3 lights में देखें. Look into 3 lights. And I will first go for the side port incision. And look into 3 lights. नीचे देखें. I am doing under topical anesthesia. सामने 3 लाइट में देखिएगा मैडम. मिसेस गुप्ता, आपको ये सामने देख, घबराइए नहीं, लाइट में देखें, हिलाइए. 3 लाइट में देखें, हिलाइए नहीं. करेक्ट, वेरी नाइस, वेरी गुड. So our paracentesis wound should be 1 millimeter size, and this is done. सामने ही देखते रहे आप, रिलैक्स होकर के सामने देखिएगा मिसेस गुप्ता. आप बहुत अच्छे से कोऑपरेट कर रहे थे. Very. And my second, this thing is again on my left hand side, and I will make it smaller because my chopper is less than 1 millimeter size. So I will fill the chamber with phenocane. This phenocane has lignocaine and phenylephrine. And I will stain the capsule. Now, आप सामने ही देखते रहे. Very nice, very बहुत अच्छे से करा रहे. I will stain the capsule.
What are your views on use of intracameral anesthesia for such uncooperative patients, sir?
Actually, for VVT and all premium lenses, she is very cooperative otherwise. And the reason is that centration of the lens is very, very important in these premium IOL cases. Toric IOL and into the light.
Good morning, Ranchi, and good morning, Kashyap as well. This is Dr. Tejas Shah, trying to read Dr. Purinder.
We place the PSA, the trap and
So, Dr. Purinder, do you always stay in the capsule?
No, no. But here I am doing it.
Yeah, for the sake of demonstration, you are okay.
In such case, I don't really require.
Yeah, and such a luxurious microscope, the Luxure Uralia from Alcon. This is a beauty.
So I am replacing the air bubble and BSS with methyl cellulose. Look into the light.
I think this was very well done because you removed the entire pockets of PSS. You started right from the other side of the eyeball.
सामने 3 लाइट में देखने को मिला लाइट के अंदर देखो हाँ सामने इधर लाइट के अंदर लाइट सामने लाइट में देखिएगा आप कॉपरेट करिएगा ये बहुत जरूरी है अभी तो नाउ अवर फोकस शुड बी ऑन द एंटीरियर कैप्सूल ऑफ द लेंस सामने लाइट में देखेंगे रेडियन में एक्सिस दिखाइए सामने लाइट देखिएगा मैडम ऑपरेट करिएगा हाँ दिस इज एक्सिस so my axis is almost 5 millimeter size.
Dr. Purinder, you like a cystotome versus a forceps? An Utrata forceps for the capsule axis?
I am an old timer.
Just like me.
So yeah, so I have learned with cystotome only, but definitely Utrata with Utrata forceps your control is better, and I convert when we have to focus it, and with small excursion we have to complete it. And because we are doing a live surgery, that's why we have to do it. This is how it is completed.
Excellent, excellent capsule axis.
By making it horizontal. Now we will enter, and this is I do hydrodissection with the flat cannula, so that, and you see, I will go underneath. Some air bubble was there. So I will remove the capsule. I will go underneath the capsule and lift it. You can see the fluid wave going to the other side. Release the fluid from the back, press it down slightly, and rotate the.
Dr. Vanati, Dr. Balla, is Dr. Purinder very well audible?
Yes, sir.
Okay.
Yes, very well audible here, and I think he's doing a wonderful job on an eye patient who is trying hard to focus for us. A little wetting on the ocular surface will also help him, I guess. And some of the beginners here, if you find this difficult and if you find this patient as uncooperative, we do have fixation rings like Taunton rings, which you can use to fix the globe, especially when you're using, when you're doing topical surgeries and when you feel the rexus is going to run away or you're feeling a little apprehensive because the patient is not able to fix at a particular point when you're doing your rexus. Those are some tips for you to achieve better control of your rexus on an eye which is continuously moving when you're doing your rexus here.
Excellent comments from a real teacher. Dr. Vanati, that was super.
Thank you, Dr. Vanati. So this is this thing.
Yes, Dr. Purindra, I can't get what you're saying.
That was Dr. Tejas. I said excellent teacher as always. Dr. Vanati, your points were well taken.
Thank you. Hi, Tejas.
Yes, hi. So Dr. Purandar is going to use the Luxury Rivalia microscope from Alcon and the Centurion phacoemulsification vision system from Alcon. And very soon he will tell you about the other features of the machine.
That was the Sense-Q. Now this is the chopper which has been designed by you.
Can you just can you
This is
demonstrate it
the-
outside?
Yeah, this is the chopper.
Centration.
Which is,
Centration.
yeah,
Yes.
which is designed by me. And this is the blunt chopper. The tip is blunt, but the inner side has got a cutting edge. As you can see, it is and its length is around 0.8 millimeter. It's not very long, so there is a little chance of damage to the posterior capsule. So now we will go for the phacoemulsification.
Dr. Ballad, do you have any particular preferences in the kind of choppers you use, or do you use different ones depending upon the difference in the density of the grade of cataracts?
This can be used universally, but in very hard grade 5, grade 6 cataract, I use the sharp chopper.
Hook only. But for denser cataract, grade 3 and above, I use sharp chopper of Amar Agarwal. That's a sorry, Mohan Rajan. That's a very nice chopper. It comes in various lengths: 1 millimeter, 1.2, 1.5 millimeter.
This is I'm using a Centurion machine.
Yes, I use sharp choppers in those, but in softer nucleus, I use Sense-K hook only.
Yes,
So I have started doing phacoemulsification.
yes, Dr. Purandar, continue, please.
This is I'm using Centurion machine, and my setting is the like. Pardon? Can you see my settings on the screen there?
Yeah, we can.
So my IOP is 55. This is a pretty soft cataract because our age is 40. You have to center it and keep it focused every time.
So, a surgeon like me would like to use horizontal SOP in softer grade of cataract rather than going for a direct SOP. What's your view on this, Dr. Purandar?
Yeah, definitely. You should go.
Dr. Abhijit.
So it's a very, grade 2 cataract. I think reasonably soft cataract. So he is getting problem with the getting crack. I think.
Yeah, true.
In fact, one of the very important rules is that you should not have a saucer left behind. And if you are left with a saucer, it becomes a bit difficult. So the first initial crack is always so important. Even if you can just make one single crack, it's okay.
Actually, this was on pre-FIGO setting. I'm sorry. That's why I was not.
Yeah, he was not able to hold.
Yeah, now I will. You see. Thank you, sister, for reminding. It was our mistake only. इधर से मेरी तरफ करिएगा मैडम.
So it is a soft cataract. So it is very difficult to get a full thickness chop.
Yes, many times it happens.
Now I will demonstrate the chop also.
Last time here, we are using
because it was not on my particular settings.
This is the Sentry handpiece, and Sentry handpiece has 3 advantages. Number 1, it just compensates for the wound leak, and the number 2, it detects the anterior chamber changes very fast and compensates it because it has a sensor in the
handpiece itself.
Handpiece itself. And the third thing, it automatically takes the care of eye level. वो तुरंत आंख लेवल पे खुद ही आ जाता है।
Sensor is at the tip of the
ये
rainbow
सेंट्री
entity.
मैंने
So
भी
that is the reason
डाला था
it
JHOSCON
is very fast
किस किए थे,
down, and chamber stability throughout, as you have seen,
सुना
is
था
better.
is not good.
I will
I
enlarge my
did myself. I found it is good. आपका क्या एक्सपीरियंस है मैडम विद द सेंट्री?
The Sentry is a continuous phaco-fluid dynamics in the eye. So instead of having your sensor in your phaco console, it has moved into the eye level and in the eye. So as you rightly said, it helps you in dynamic control of the intraocular pressure depending upon how the fluid is causing changes in the anterior chamber dynamics here. So that's a huge advantage, especially when you're compromised posterior segments like, optic nerve decompensations, post-glaucomatous atrophy, post-optic atrophy patient, post-TRAP patients. Here, it causes a dynamic variation of the intraocular pressure. The huge advantage being the sensor has moved into your handpiece rather than being in the console here.
Actually, I am using the bimanual irrigation aspiration from MST, and this got a polisher also. My aspirating handpiece is sandblasted, as you can see. So you can do PC polishing also easily with it. And then you have to go underneath the capsule, hold the ledge of the cortex leftover, and so bimanual gives me advantage to remove the cortex from 360 degree, and even in sub-incisional region, we don't have any problem. You can exchange the hand, as you can see here.
I think Dr. Vanati and Dr. Bharti has very nicely enumerated the advantages of active Sentry handpiece. We glaucoma people are really find it very advantageous because the gravity-based infusion has a lot of problems. 100 centimeter bottle height will induce intraocular pressure in the eye for about 70 millimeter mercury, which in moderate to severe glaucoma can really lead to a lot of problems. You have done a very nice uneventful surgery, and post-operatively you find that the glaucoma has even real chances of snuff out phenomena. But your intraocular pressure of 30, 35, and since there is no gravity-based infusion, so it really helps you. At lower intraocular pressure, you can do nice surgery with well-maintained anterior chamber. Even if there is slight amount of wound leak, it really takes care of everything. And so it really comes into play. And this lower intraocular pressure surgery with active Sentry handpiece is very beneficial for these group of patients who have moderate to severe glaucoma or where you find that the optic nerve is compromised. I think it's a big advantage there.
The advantage of this machine is the chamber stability.
You don't have active.
You get a very good chamber stability.
Normal thing. Only thing is, don't go in position 1, go into position 2 straight away once you enter, because then that gravity based IOP which rises can be taken into account. That because if you are in,
I have polished the posterior capsule, as you can see,
will be much lower than what is
posterior capsule is distinct. And this is how the case is done. We will fill the chamber with viscoelastic, and I will be using the Alcon VVT lens examination.
Excellent demonstration of the surgical skills. Well, we sometimes forget that there is a man behind the machine, and we need to congratulate the man behind the machine too. Dr. Purendra, that was an excellent surgery.
Yeah, look,
nice round rexes, as good as femtorexes, and very nicely clean surgery.
Absolutely.
The posterior capsule is pristine clear. Now the good part is that I am getting very good red reflex throughout this is because of this new microscope. I am using it for the first time, and I have been using Lumira microscope, but this is Alcon, what is Rivalia?
Yeah, luxury Rivalia.
A wonderful this thing. So I will show how the lens here, and this is Alcon VVT. This is something which has got a the 1 micron button on it. It's a plateau which is in the center. Yeah,
Yes, you can. Yeah, we can see. Slightly centration, please. And just, yes, a part of it is visible.
Now
Yes, now it is. Yeah, it's very difficult.
it's difficult.
Yeah, you can decrease the magnification and then you might.
So I will be showing the loading of the lens. You have to hold with the haptic part. Press the optic down. Hold the trailing haptic on the surface of the lens. And I am using a D cartridge which fits in the lens and slips the lens to a 2.2 millimeter LCD. And the lens is folded, pushed. I will go back to the. Usually my assistants they fold the lens.
Very true. We are all now lazy.
Look down. Yeah, we.
And probably.
No, they are doing good. Viscoelastic.
Yeah.
Otherwise, this is going to rebound. I will focus it once the lens is pushed inside. Oh, ऐसा नहीं करिए देखिए ये मेरे को blue forceps. I have to load the lens again. Easy. मैं और अभी दबा डालते हैं. अभी ये lens loading forceps थी ना वो देखिए. ये blue वाली lens loading. I will. नहीं. Once. नीचे देखेंगे.
Now, this is the good thing you are seeing actually. For the beginners, the lens is stuck in the wound. So Dr. Purendra will come out successfully. But this is the one complication where the patient is not cooperating that much and moving his or her eyes or head also. So that inside the wound, when you are pushing it, the cartridge, it just dissolves from the cartridge and it's stuck in the wound.
Absolutely. The patient was also not looking the correct way. And this is a part and parcel of what we all do.
Now the problem is if you push the lens, that wound will increase and the lens that other trailing haptics can break. So it's better to come out with the lens. You remove the lens, you place once again to the cartridge and push it.
Let's see what Dr. Purendra is trying to do.
I'm trying because most of the 70% of the lens has gone inside. So I'm trying to push the remaining lens inside and I'm able to do it slightly.
Yeah. Very nicely. He's only touching the last part of the optic and not the haptic, so that the haptic will not break. And I think he's nearly successful. So I believe that was a delivery through an episiotomy.
Yeah.
No.
Excellent.
Excellent.
Very nicely done.
So we have witnessed how the complication can be tackled.
Very, very important. And frankly, a lot of people, members in the audience, are looking forward to it. And Dr. Purendra served them well.
Yeah, actually, all these things, because life surgery gives us the demonstration of life problem which we face in day-to-day life. And I have to push the haptic.
Yes. So if you are a phaco surgeon, so you should have maximum patience.
You should patience or patients. We all want X number of patients.
Now, the important thing is that this lens has to be centered. The three Purkinje images of the microscope, that has to be centered at the the plateau which is there in the center, which is of 2.2 millimeter size. So, and the height of the plateau is only 1 micron. Unlike in panoptics and other multifocal lenses. So this lens is the advantage of this lens is that it stretches the wavefront, and it provides the extended depth of focus and intermediate vision at 40 and 60 millimeter to the patient, which is required. And you can see the dashboard, and you can see work on the mobile, and so this is, you can see the plateau.
Yes, yes. Very well,
Center
very
1
well.
millimeter, and then total 2.2 meter. And this is properly centered in the plateau. Can I have hydro? So I will hydro side port, bring out the eye. I'm sorry, the patient was not very cooperative, but सामने देखते.
Yes, rightly said. It's the man behind the machine who's more important than the machine. And you've seen when the patient is impatient and the surgeon has to be patient.
Yeah.
I think the good learning points from this surgery is that when you are watching a patient who's constantly moving an eye, and when you are inserting a lens in that patient, always try to fix the globe here, because as you're trying to push in, because that's the last step, which, and then you're almost done, and with the patient tends to look away from you, then this is what happens, and the lens will tend to get stuck in the wound here. If stuck with more than about 6% inside the eye, then pushing in the lens like this very, very patiently, always here. So two things important here is calm yourself down, calm your patient, and then patiently wait as you're pushing in, and very gentle movements here. And also fill your viscoelastic well, keep it taut, so that when the IOL is pushed in, it's not going to go in and damage your posterior capsule here. But if 2/3 is outside, then you will have to contemplate other methods of how you will have to remove your IOL and reinsert it for optimal results here.
In fact, very true, Dr. Banati. And that's the reason I do not prefer a screwing technique of implantation. I rather always want a push technique, because my other hand is always stabilizing the globe with the help of some instrument from the side port. And that is one way of stabilizing the globe.
I think that is very important. That
Yes.
Our other hand to stabilize.
Yes.
The but in this particular case, she was totally.
Yeah.
She moved her eye against our this thing. But anyway, at the end of the
All is well that ends well.
And I have released the extra amount of VSS which was there, because I have found that the pressure IOP was higher side. So I released that, and this pressure is adequate now. There is no leak from anywhere. Wound is excellent, and some air bubble is there, which I don't want to remove now at the end, and this is going to absorb in a day or two. And I'm thankful to Kashyap Hospital, Dr. Bharti, Dr. Kashyap, for giving me this opportunity, and Dr. Vanati for the comments which you have given, and Dr. Balla in between. And anything you want to ask, I'm very happy with this Vivity IUL. To me, this is one of the finest lens which we have seen, because it doesn't give any glare, halo, or any visual disturbances like a starburst, etc. Because it's like a more like a monofocal IUL. You can and the studies have compared, and we have done almost 100 lenses by now. And in all our cases, we have seen that the visual quality is good, and even in the compromised cases, like in the cases of the macular pathology or ARMD, instead of our diabetes patients, where we are not interested in doing a trifocal or multifocal lenses, these lenses are really good. And he being a young diabetic,
Altogether, and we have enjoyed watching.
not get as good as their vision. 25% of the patients, my experience is that
Surgery.
we get a N6 vision also. That is also we have seen in few cases in binocular vision when we implant bilaterally. So do you advocate a small micro monovision or small micro? Yes, not much. Small and micro. Yeah, small micro monovision that helps in giving the better quality of vision in these cases. But nevertheless, Panoptics is also a wonderful lens for which gives us a tripopility. And I'm really happy to see the relaunch of Nazar microscope from Alcon by name of Rivalia. Had a very good depth of focus and it is very smooth and we get a very good red reflex throughout. So that is another thing and without compromising quality. And this Centurion was very good throughout the chamber. It was formed and there was the only thing is that in our technique, our side ports, our main relate with the size of our sleeve and the side.
Your voice is not very clear. Can somebody at the audiovisual speak?
Yeah. Is it better?
It is better now. Better.
The thing is, what I say is that our ports of the lens of these incisions of the surgery
Your audio
that should match with the
to improve it. Your audio is not clear. We are not able to understand the language.
Oh. Can you stop?
I think what Dr. Purendra was.
Is there echo is there or what? What? Now is it better?
Slightly better, sir.
But echo is too much still.
Okay. How to do? What is it?
I think for he was telling about the Vivity lens. It's on an Alcon platform. It's a non-diffractive, aspheric, extended depth of focus lens. It induces negative swelling.
Yeah, this is extended depth of focus lens, true extended depth of focus, and we get unlike eye hands or other lenses, this gives a better near vision.
Exactly.
So yeah, and what I wanted to comment is that our incisions, our ports should match with the instruments which we are using. If our eye is different and it is a 0.8 millimeter or 0.7 millimeter, our port should not be larger than that. Otherwise, there will be a leak and the iris touch will be there, iris and people will start coming down and all those problems associated will be there. And that is the crux of of the surgery. It is nevertheless very well taught and we have learned it. But people really miss it when we do the surgery. We find that the incisions can be 1 millimeter. Main port should be 1.5 in all our cases. That should be there, and it should not involve the conjunctiva. Rhexis should be centered, and the Varion Rhexis help us, giving us the central Rhexis. And incision, what I do is, in my cases, I make an incision at a steep meridian in all my cases. So that decreases the, as far as possible, unless until it is very away from my, I do it on a temporal side only in all my cases. So if it is say 25-30 millimeter, temporal, supratemporal or infratemporal, then I really feel that I should do it on that axis, that meridian, and definitely we can give an edge to the patient, better quality of vision that will decrease the astigmatism, and you can do better from your competitors and from your neighbors. That is the message. The most important thing. That is the most important message is. So if you give something extra, that patients remember and they say that my vision was 6.6 from most of our cases are good. So IOL power calculation is also very, very important. So I do the IOL power calculation with multiple equipments. I use IOL Master also 700 and in premium cases I check it again because it may vary and on the day of surgery also sometimes I do, and we can check the keratometry and counter check it with pentacam, and that all this will help us in planning of a toric IOL or toric multifocal or toric VBT lenses or EDOF lenses. Thank you. Thank you all.
Yeah, Dr. Purender, like the VVT gives you very good distance, intermediate vision, and functional near vision. And do you believe in having micro vision philosophy in this increasing?
When micro monovision, I do in cases where I feel that it is necessary and it is required. But in housewives, I think if you do it in both the eyes, if you do of the exact power, that helps. But in those who require a good near vision, like those who require reading, those who have a reading habit, then I go for a micro monovision. Otherwise, binocular surgery, if you do with the VBT lens and there is not much of astigmatism, then it works very well. It helps us, and even without doing a micro monovision, we can do it. Dr. Tejas?
In fact, for us, it's a rule. All non-progressive lenses, there is a monovision, micro monovision, and for a monofocal, it is minus 0.5 and minus 1.25 also. But we explained to the patient before, and most of the patients understand. The first and most important thing is not to compare each eye's vision, because when you do a monovision, the patient invariably keeps on comparing each eye, and that is something which is against your practice, because the patients are not going to be able to envisage that, okay, my monovision was done. So we need to spend a lot of chair time whenever we do a monovision, micro monovision or monovision. Thank you. I believe we are moving on to the ERM.
Please stop screen sharing.
Dr. Vanati, anyone else? Dr. Abhijit, any question?
We are moving to vitrectomy for a brief period, and then we will come back with ERM peeling starts. Dr. Vibhuti, please start OT1.
Please correct the audio from inside the OT, because here it is not clearly audible. 90% words are missing. We are not able to understand what is being spoken from within the OT.
Clear.
Good afternoon, everybody. Am I audible? I'm speaking from OT3. Is this audio good? Then we'll use this microphone.
Good afternoon, everyone. This is Dr. Vibhuti Kashyap from OT1. Am I audible? Good afternoon, everyone. This is Dr. Vibhuti Kashyap from OT1, the VROD. Am I audible?
इसका वीडियो इज गुड बट ऑडियो इज नॉट गेटिंग दैट क्लियर। जाहिर सी बात है कि इट्स अ रेटिना सर्जरी, तो ये पूरा चारों तरफ से तो दिखेगा नहीं, दिखेगा तो बस बीच का दिखेगा।
Audio. Can they improve?
होना चाहिए।
Ground star, am I audible?
हाँ हाँ बोलो, फिर से बोलो। हेलो।
Good afternoon, everyone. Am I audible?
Yes, you are audible.
All right. So good afternoon, everyone. This is Dr. Vibhuti Kashyap from OT1, the Vitreoretina OT, and today with us we have Dr. Anirudh Maiti from Calcutta, a very senior Vitreoretina consultant and surgeon, and also the director of Global Eye Hospital, Calcutta. Over to you, sir.
Thank you, Vibhuti. Am I audible?
Yes, sir, you are audible.
At the outset, I would like to thank Dr. Bharti Kashyap and Dr. Vibhuti Kashyap and the entire Jharkhand Ophthalmic Society for inviting me and giving me this opportunity. Well, I will be operating today on an epiretinal membrane and pseudohole. This patient had already undergone surgery in the left eye for a macular hole, and this was in a left eye done elsewhere. The best corrected vision is 636, had a type 2 closure, and this eye, that is a right eye, it has an epiretinal membrane with the pseudohole, and the vision is 636. So we have already done the vitrectomy. Can you see the screen? Is it clear? Is it focused?
The white we are seeing the. Hello.
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 Yes, sir. Can,
What we are seeing is the TCA.
yeah, we have completed the core vitrectomy and induced the PVD. The PVD induction is already done. What you are seeing is the remnants of the triamcinolone acetate, and we are going to clear that off before staining the ILM with PVG dye.
Is it the Constellation machine you are using?
The Constellation machine we are using, and the weaving system is Biome. You can see the remnants are coming off. Once we clear this triamcinolone acetate, we will stain it with the BVG. And obviously the epiretinal membrane, it will be negatively stained. So we will use this negative staining property to remove the ERM first and then pick up the ILM if required.
So we have really missed one of the very important point of the PVD induction.
Actually, this patient is a 60-year-old female patient. The PVD was incompletely already done. So when I started the core vitrectomy, it was already done. So I cleared off the remnant of the vitreous. So once we clean it up and then we stain with the BVG dye, we can shift to the other OT for the cataract OT. And once the staining is done and we start peeling, we can again join. Right?
So with partial PVD, what was the purpose of using this triamcinolone?
I wanted to be sure that the entire PVD has been taken care, because sometimes a thin layer of the vitreous stays in the posterior pole, which actually hinders the staining of the ERM and the ILM. It's always better to stain with triamcinolone acetate in all cases of the retina, because we need to be sure that no remnant vitreous is left behind.
What would be the extent of PVD you would do otherwise in a case of a?
We try to clean up all the vitreous. The total PVD is mandatory, and the peripheral screening is also needs to be done.
Can we use proportional reflex to wash off this?
Yeah, I will now use the active extrusion or the proportional reflex to wash off and then put the PVD.
Thank you, sir. So meanwhile, we'll be shifting to the cataract OT for the Clarion IOL, and we're going to come back to this surgery to view the staining and the peeling of the ER. So for now, I'm handing it over to the cataract OT. Please stop the screen and the voice sharing and
So there are a lot of best protective and
Yes, pressure.
बंद कर दीजिए। धीरे धीरे
Hello, good afternoon. Are you audible?
टाइट हो रहा है क्या? Easy.
Yes, you are audible, Dr. Subhadar.
Yeah. So Pooja, is Dr. Pooja audible?
Okay.
Yeah, you are audible. You are audible. Pooja is not audible.
So you want to speak from here?
Watch कर
Okay,
लेंगे
I'll just
इसमें, उसके
share
बाद
the case
मैंने
details once. 64-year-old female. She's posted for left eye cataract surgery and she's been done under topical anesthesia. Rate of cataract is
Pooja, you are not audible. You are not audible properly.
Okay, so this is Dr. Paul. We are doing a patient who is 64-year-old, grade 3 cataract, left eye you are doing, and the sleep axis is superiorly. I think my setup is being shared on the screen there. It is grade 2 cataract, and I'm using the upper semi machine, upper semi microscope with step magnification, which I haven't used before. So please bear with me if required. So please keep and watch. So at the beginning, I'll give the 2.2 millimeter incision with the keratome, and with the same incision, I'll incise the capsule to raise the flap. That's the technique I use for last 20 years. And then I'll inject visco and do the side pores. And then I'll do the rexis with Valipulkar forceps. So, and then we'll go ahead with the phaco. So this is under topical anesthesia, and we'll be starting now. So I am not holding any the eye, depending on the patient. माजी आपको अभी सीधा देखना पड़ेगा और कुछ नहीं, हाँ, हिलाना मत, हिलाना मत, हाँ, हिलाना मत, सीधा देखिए, हिलाना मत. So the incision is done, hilana mat. And I've lifted the flap there. No, क्या कहा? Maji सीधा देखिए, because the lady is lying there for last 45 minutes, I think she has become tired as well. So you can see the flap. Maji, आपको एक ही काम है, हिलाना मत. Probably it would have been better if we had stent the capsule. Now, because the eye movement is mainly downward, what I am doing, you can see I'm using the side port with this cutting edge looking down, so that even if she moves the eye downward, it will not extend the wound. Blade is blunt. The blade is very blunt. आप दोनों आँख खोलिए, दोनों आँख खोलिए, लाइट को देखिए. Light को देखिए. This is tape magnification, so I cannot actually magnify.
तो यह सस्पेंड नहीं होगा.
Is the capsule focus? This is only to the process from the main wound. The flap is already lifted. इसको हमने रखे थे.
See, so if you are using a microrexis forceps, you should go through the main wound. Otherwise, the microrexis forceps will not go that easily.
पहले तो सर को फेलिसिटेट सर जब रिम्स को फेलिसिटेट करेंगे किसी को भी रहेगा राहुल
सीधा देखिए माजी. The rexis is done. So I'll let out some of the visco.
Magnification
And you can see the flow of the fluid there. So I'll be using phenocane. Phenocane I use routinely because even if the pupil is dilated, it maintains the pupil. And this normal disco. And now I'll inject disco in the anterior chamber. This is a deep set eye, but I'm doing from superiorly because of the steeper axis. Stopper. And I'll be using this chopper, which is 1.7 millimeter sharp pointed chopper. So with that only I'll rotate the nucleus.
Dr. Sugato, you use sharp chopper in all your cases?
Yes.
Okay.
I use only two instruments, that's the Rexis forceps and the chopper. So this is balance sheet. We are starting with 20 pressure, but I think I'll have to increase the pressure because this is slightly shallowish and patient cooperation is also required. And the cornea is also slightly heavy because the patient was waiting with the speculum on for last 40 minutes. Look straight. Sorry, आलो को देखिए माजी, लाइट को देखिए, लाइट को देखिए, ऊपर देखिए, थोड़ा बीच को डाल दीजिए ना। आप तो हिला रहा है कंटिन्यूअसली, लाइट कम हो गया क्यों? माइक्रोस्कोप को लाइट कम हो गया क्यों?
So it is very difficult for the beginners to get into the phaco probe inside without the side port support.
पेन हो गया वो पिलाने में ज़्यादा ये नहीं हो जितना ज़्यादा
Excellent, Sugato. You've wonderfully shown how to do direct chop in a soft cataract. Really
But
wonderful.
the chop was not pressure थोड़ा increase कर दीजिए. 30. The chop is not complete, so I'm moving away. See, this is the problem in doing light surgery because the food control and things differ slightly. So you have to be very careful. So my chop is done that side. And it's very soft cataract actually.
Attention, video has gone off.
Is the video there? उधर वीडियो नहीं मिल रहा है उधर. मिल रहा है उधर वीडियो और इधर डिवीजन So I don't take out the thing during the last removal. Actually, I got the PC. You can see the position of my chopper.
It's being tilted behind the top, behind the phaco. So if the PC comes, that will protect the PC. And then once I have done the thing, I'll take it out. So that is slightly different. Someone prefers taking it out before removing the last tip, but I keep it on. So now I'll be injecting Visco. Now tip for the beginners, whenever you are injecting Visco, please hold the cannula. Please hold the cannula with the, hold the cannula because so that it shouldn't be running out because it's a, is the video visible there? Is the video visible? सीधा देखिए माजी सीधा देखिए आप इतना क्यों हिला रहा है देर लग रहा है आप फोन करके फिर हिला रहा है आलो लाइव देखिए माफ हिलाइए
But audio is not coming. Please correct the audio also.
Am I audible?
हेलो हाँ आ रहा है सर आवाज
Yeah, so you can see the phaco has been done. I am not sure. I can't see the phaco time. Can someone tell me the phaco time?
CD is 0.59, sir.
So it was a soft cataract where I demonstrated chopping, which is very difficult. Now I'll be doing the IA. So initially, because I'll be injecting the lens under irrigation. So first I'm using my left hand to do the IA and then I'll swap over to my right hand. थोड़ा सा side को दीजिए ना.
Sugato, you have increased your IOP to 60 now?
For the IA, yes.
Okay. Otherwise, for nucleotomy, you are keeping at 20 to 30.
20 to 30, yes.
Increase.
I'm working on the IOP for the irrigation aspiration as well, where I'm nowadays normally using 40, but you know, in the life surgery where the surgeon is checking as well, so I don't want my hand to take the posterior capsule. So I'm just joking. Yeah. So I've started with IA with my left hand.
So Dr. Sugato, you are using a wider bore irrigation aspiration, so that's why you enlarged your side ports.
Yes, that's whatever I have got here. Yeah, but one advantage of this is the chamber during the aspiration surge is much less with the wider bore.
You can do it pretty faster as well.
Yes.
Do you alter your phaco fluid dynamics when you're using a wider bore, or you would still continue with what you have for your?
I normally continue, ma'am.
Okay.
So now I'll shift over to my right hand because I'll be.
Sugato is showing very nicely how to catch hold of the anterior lip of the cortex and not the posterior lip, and just pull it centripetally.
So the lens is ready.
One thing is very evident that he is pulling this tangentially. That is very important.
Very important, sir.
Very important. If you are pulling,
Hold sideways movement and then pull centrally.
excellent.
Ready, go ahead.
Sugato, very nicely done. Perfectly round rexus. Surgery.
which lens you are putting?
So this is the problem with this lens. You can see it has opened other way around. So I have to manage now. Side port. So you can see it has opened other way around.
Is it an Alcon lens?
Yes.
This is ultrasound, sir?
Clarion.
Clarion.
Problem is you have no control how the haptic will go. So I've rotated the haptic now and I've placed it inside the bag and tangentially. So no viscovas is required. And now I'll hydrate the wound. And if Anirudh is ready in that room, you can shift the wound. And I'll thank you everyone for watching patiently. This side foot wound was slightly bigger than what I wanted to make because the the keratom tip was slightly blunt and it went in with the pressure. As you have seen, I don't hold the eye at all at any stage during the rexis or during the keratom incision and during the side foot incision. I depend on the patient cooperation basically. So the eye is absolutely white and quiet after the operation. And other thing is that two things, IV antibiotic, is it here? So two things, one is IV antibiotic, and because premium patients, they do complain about irritation. Maji सीधा देखिए हो गया बहुत बढ़िया हो रहा है. They do complain of irritation, so I do use cysteine hydration routinely after operation, which is basically sodium hyaluronate drop, hyaluronic acid drop, which has been just put in, so that the patient is much comfortable after the operation. Thank you very much for watching.
One thing I want to give one trick. When this type of haptics get turned away from and you have got a difficulty in loading, so what
I
you
just
do
want
that
to take the
after
opinion of
inserting
all the
IOL,
faculties here.
you just close the tip of the nose, tip of the injector with the finger and then push it, so the haptics get turned inward, and then you don't have any problem of rotation like this.
Yeah, that's what I do normally, but because it's a auto injector, but before you react, sometimes it goes out of the thing. Otherwise, if the haptic is like hand products, if the haptic is producing, you just hit the irrigation cannula, bend the haptic, and then go on injecting the lens. That is separate, but with Clarion, this is the issue. They do suggest using viscose to the strip. So I don't know whether my assistant did that. Then the hand rub chances is much less.
I'll repeat what I am saying. In eyesight lenses or this type of lenses, the haptics get turned away and you have got a difficulty in rotating. Now, what that after you close the tip of the injector and push the lens, so that the haptics will get automatically turned inward, and then it will go in a natural.
Okay, that's a nice tip, sir. I'll try that.
Thank you, sir. Wonderful tip, sir. Now we are in the retina OT.
Meanwhile, when the retina OT gets prepared, I just wanted to ask Dr. Sugato, are you using intracameral moxifloxacin? Intracameral moxifloxacin.
Two things. One is intracameral moxifloxacin and a drop of cysteine hydration on the top. These are the two things. One, intracameral moxifloxacin, which is made by Encode. They have, and there are other companies as well. One thing, if you are using intracameral moxifloxacin from the eye bottle drops, remember not to use MXG eye drop, because that has gum, that has xanthan gum in it. Is made by Lupin, which is a very good eye drop. But if you use that intracameral, because of the content of the xanthan gum, it will cause stars. So don't use that. But any other, I use Digamox or Entol intracamerally and cysteine hydration topical few drops after the end of the operation. Previously, I used to put a little bit of visco over the cornea. Now I use cysteine hydration.
I think very nicely said. It makes there is a literature based evidence to use intracameral moxifloxacin, And the mice of most of the organisms causing endophthalmitis is about, yeah. Is about
OT1 in the retina OT, are we audible?
OT1, you are audible, and the video is also very well seen. We are just felicitating our president, AIS. He has just arrived, and yeah. So you can.
Yeah, are we audible from the retina OT?
Yeah, exactly.
Yeah, all right. So welcome back to the retina OT, and Dr. Matthew is all ready for the ERM field. Over to you, sir.
Yeah, we have stained with a BVG dye, as we can, as we were mentioning that we use this negative staining property. The ERM doesn't stain with the BVG. So you can see the central part where the ERM is there, it is not properly stained.
this you have stained with
Otherwise,
BVG dye, no?
peripherally, the ILM is nicely stained with the BVG. So now we will pick up the edge and then gradually remove the epiretinal membrane.
You should
Pick up the edge. So that's the edge of the epiretinal membrane.
The periphery is more important also. Yeah, I see the OCP. OCP में जहाँ थोड़ा separation होता है ना. Yesterday only वो upper vessel arcade पे सबसे बड़ा separation था.
Yes, this is the membrane. Can you see the membrane? It's coming up. Can you see the membrane?
Is the membrane visible getting peeled?
Yeah, very nicely, Matthew, very nicely.
Very nicely, we can see it. You moving the ERM, peeling it. Fantastic.
Fantastic. Matthew, I am Lalit Verma here. Very nice.
Thank you, sir. Just clean it up.
What is negative staining basically? ये माइती की बस आवाज नहीं जा रही.
So this ERM doesn't stain with this BVG dye. So we get an light from where we need to peel the ERM. Generally, we start with the stained ILM part, and then once we get the edge, we pick up the ERM. And once we have done it, we will stain it again to see whether there is any remnant of the ILM is left behind. So that's what we will be doing.
So this is basically patient of ERM basically.
It's a ERM, sir. ERM with a pseudo hole.
What is your plan? You remove ILM in all patients of ERM?
I try to remove in all cases of ERM.
But the hair is nicely stained. I think you can easily do that.
Yes, sir.
What was the indication for removal of ERM?
The vision was dropping down and it had a pseudo hole and there was a progressive decline in vision. In fact, the other eye had a macula hole which was operated previously. We can actually show the OCT. Can we show the OCT? Yes, sir. By the time it is stained.
No, no, it's not visible.
थोड़ा नीचे कीजिए कैमरा थोड़ा नीचे कीजिए और नीचे कीजिए good.
But this is a partial thickness hole.
Yes, sir.
Of the other eye.
Basically a pseudo hole, basically ERM removal has different indication because patient can have intolerable metamorphopsia. The commonest indication of ERM removal is metamorphopsia, not decrease in vision. That is my commonest indication.
Vibhuti told that this patient had come before with 618 vision, and then gradually it deteriorated to 636.
Yeah. Because if during your vertical follow-up, you document that vision is decreasing, then it's okay. But my common indication of operating in a ERM is
It will be the dysmorphopsia and distortion in vision.
Good afternoon, sir. This is Dr. Vibhuti Kashyap here.
So this is what I wanted to highlight. We do not operate the OCT findings. We operate whether the patient has got a good vision, symptoms, distortion of vision, other things are not purely on the basis of OCT findings.
Sir, am I audible? This is Dr. Vibhuti Kashyap. Am I audible?
yes, Vibhuti, audible. Vibhuti, you can speak.
Yeah, Pranam, sir, and welcome to Rajiv. Sir, actually about this case, so this patient had a 618 vision on initial presentation, and the patient already complained of a metamorphopsia.
Yeah.
My actual indication for an ERM removal is also the development of a metamorphopsia, and that was when she was planned. It was during the follow-up for her pre-operative test that she developed further reduction of vision.
This is Mehdi, what you're removing now is the ILM.
ILM, sir. Once we have removed the epiretinal membrane, now we have stained the ILM very nicely. Now I can easily pick it up and remove it.
Very nice edge you have created.
Little bit friable, it's just not coming in one go.
You see, unlike macular hole where it comes in a single sheet, in ERM patients, it does not come as a single sheet generally.
Yes. In any case, this patient is not a macular hole patient, so we will not do it from arcade to arcade. We will remove the posterior pole. That's what we have already done it. Yes.
वो ट्रैक्शनल
थोड़ा क्लीन कर देना। Yes, we can.
100%.
I think we have already cleared the posterior pole, the ERM as well as the ILM. Now we will do a fluid air exchange and changing the lenses.
This should suffice. This should suffice.
Thank you.
Thank you so much, Mikey, sir. And now we'll be shifting to the cataract OT for Dr. Tejas Shah's case.
Very nice job done, Maiti. Very nice job done.
Yes, sir.
Over to OT3, please.
Please share the OT3. Yeah. The microscopic view. Yeah, good. We can see it now. Can somebody tell us about the patient's profile and what kind of a lens he is going to put in? OT number 3. OT number 3.
Can you hear me?
Yeah, we can hear you now. You're
Loud and clear?
yes, yes. Can somebody tell us about the profile of the patient and
That we are going to do shortly. We were just trying to adjust the microphone. So, Dr. Nidhi, can you tell us about the patient?
Yeah, this is a 76-year-old male, non-diabetic. We are operating the right eye for panoptics. His vision is 624 hours best corrected. It is a grade 4 cataract with PSC. Now, his daily activities is he likes to drive a bicycle, but in the daytime, not during night. He's an old man, and he does a lot of. He's quite religious. He requires near vision as well. He's a non-scientific, and thus we are going for panoptics in this case. Over to you, sir.
Yes, thank you, Dr. Nidhi. So, some housekeeping announcements. I am a left-handed surgeon. I believe now by this time you know. I made my first side port on the right side, and that's the only side port because again I'm going to use a coaxial irrigation aspiration. I don't need the screen. This is not. This go.
There is a good, very good right reflex. Nucleus is also.
Yeah, grade 2 to 3 or
grade 2 or 3.
And it has got a positive circulation element. So, first of all, you need all the cilia away from the wound or from the eye because the cilia otherwise keep rubbing and they deplete your visibility. This is too thicker cannula. 24 cannula. My wound is smaller than the cannula.
So this is pushing the methyl cellulose.
Can you give me smaller cannula than this? So, like I said, I'm a left-handed surgeon. I'm going to use a coaxial irrigation aspiration. And so you will see only one side port. Excellent. Thank you. So this is the routine is for asking the methyl cellulose. You have to be very particular. Start from the 6 o'clock or the port or the side away from you and try to remove all the aqueous pockets or whatever amount of aqueous is there. And if you see, it's all getting pushed and coming out of the side port incision. So I need the microphone. I do not do my resist through the side port because I have been taught that it is always better to do it from your main incision because it gives you a lot of play so that you can move your hand and still the eyeball will not drop. So I'm going to steady the eyeball in this process only. Banerjee sir, आप left के मत जाइए. Okay, बस ये now आप move मत करना. So this is the alpha plane, I believe.
Yeah.
Yes. Okay. The beauty is that mark which allows you to actually measure and do a precise incision. So this is the part where now I will dip. Can you see the dip? So when I dip, I go inside the eye. Till then, my direction was always up, and then you dip. Again, I'm a left-handed surgeon. After each withdrawal of an instrument, the first thing that comes in my head is viscoelastic. You keep on leaving the chamber. Hey, uncle, up. Move मत कीजिए. Don't move. नहीं, अब ऐसे ही रहिए. आपको पेन भी हो रहा है ना? Okay. So again, though I did not leak any viscoelastic, but I still want to make sure. Now, texturations. The needle I bent, I could not explain because the microphone was not working at that time. So if you will see, I have bent about 1/3 the bevel of the 26 gauge cannula, and I've not kept it at 90 degrees. I've kept it at about 70. Why? So that when I'm doing it, I can see the tip. If it is at 90 degrees, I cannot see my tip. And I bent it right near the hub so that I get the full excursion. Sometimes, if I need to move away, if the axis is running away, if this is bent at half the length or 3/4 of the length, you actually keep on pushing the eyeball. And that's the reason I bent it right here so that I get the entire length of the cystodome
to work upon. Can you hold the head? Yeah, up. Thank you. I work at slightly higher magnification. Am I centered very well? Who are the moderators? Dr. Balla, Dr. Vanati?
Yes, Dr. Tejas, sir.
नहीं आप सर आपसे मैं बात करूंगा नाम बोलते हैं आपका ठीक ओके अब कुछ मत बोलना है so now I am going to raise the flap not going to cut see when you raise the flap what happens
The volume from the OT, please increase the volume.
increase the volume somebody please
Yeah.
when you raise the flap what happens is
It's okay.
especially in a mature cataract or a high intraventricular pressure cataract, the rhexis does not run away. The slit runs away, but a triangle does not run away. Now, if you see there are folds in the cornea, that means that some viscoelastic has leaked. So I'm going to come out, replenish the viscoelastic, and then do the procedure. Right? अब मुंह मत कीजिए. As you see, some viscoelastic had leaked, and so I am putting it because I want the entire iris lens diaphragm to be pushed towards the vitreous. It should never bulge anteriorly or towards the incision. Even if you need to go in and go out 2 or 3 times, it's okay. Here, for the sake of demonstration, I am going a bit slow. Now, whenever you are actually performing the rhexis, the flap should be flat and you should be very much near the shearing edge. And this should be always an obtuse. No, don't move. No, abhi aap kyun la rahe ho?
Dr. Tejas, you also do not prefer to stain your capsules when you're doing soft cataracts?
No, I in fact stain the capsule only if I do not see a glow. I have a nice Lumera, and that gives you a glow in almost all 95% of your patients.
Yes.
Right? As you see, I'm very careful because this flap tends to come towards your incision. If it comes towards your incision, it will go acute. I want it to be obtuse, so I am actually doing it slowly and trying to keep pushing it away.
So I agree that the key is being meticulous, slow, and keep changing your point of fixation with the capsule as you're rotating it, and take care when you're changing the directions.
Absolutely, very well said. And always try to overlay the cut edge, right? So the
outside
is done.
It should be from outside.
Yes. Dr. Purinder, it should be. No, Fico.
Okay. No hydro.
Correct. Yes. Chopper. The chopper. Yes. So the rhexis was done. Again, the flap should be flat. The shearing edge of the flap, that is the point where the capsule flap and the anterior capsule are cutting cutting from each other from others, should be always obtuse, and we should be very careful not to allow the chamber to shallow. So this is a sharp chopper. So frankly, I am used to only a Mercedes C-Class, but here I am getting a Maybach. No, don't move, but Mr. Banerjee, please don't move. This is the luxury Rivalia microscope. It is, oops, what is this? I stained the, see, one more complication. There is a drop on the objective lens. Can you remove it? So this is something very important. While I was trying to go in, I accidentally touched the irrigation, and so there is a drop on the objective lens of the microscope. Can somebody clean it? Can you, everybody in the audience, can you appreciate? No, not with that, with a alcohol wipe. Do you have an alcohol wipe?
Don't use alcohol.
Huh?
This is fine.
Sure, fine. I don't know.
इसको lift करके
Can you see the drop? Yes.
Ideally, it should be done with chamois leather
Yes, that's fine.
or
Yes.
the lens white. What we use for cleaning our lenses. Critical lens. Thank you.
Okay, so Mr. Giri from Elcon, he cleaned the lenses for me. And so this is one more lesson learned today.
Please focus it a little more.
Sorry, come again. Yes.
Now, fine focus, please.
Yes, I'm doing it. I'm doing it. Banerjee uncle, सीधे देखिए, सीधा देखिए. The microscope has magnetic up and down. I'm not very much used to it, but I believe now I've done it. Can you see the axis, the flap? It's still inside the eye.
Yeah.
Okay, great, thank you. So this time I'll be careful, and now I will go to irrigation. Uncle, please don't move. So I always do stop and chop because I was taught stop and chop from the beginning. My teacher was Dr. Abhay Sauda. I was very fortunate to be his only student and his fellow also. आप ऊपर मत देखिए, slide है, या easy note डाल दीजिए.
The grade of cataract, you are opening the tip very minimum actually. Phaco tip.
Come again, please. I did not hear that. Okay, so stop and chop. I usually do about 1 to 1.5 width of the paper tip. My focus for you. What is the point of deciding you have done enough? And for me, it is about going about 1.5 to 2 depths inside the eye. It's not focused. I'll come out. Can I have viscoelastic? Uncle, सीधा देखिए. No, not that. I want it in my head. I want it in my head. I need to focus again, uncle. Yes, sir. ऐसे ही रखना. So I am using the magnetic switch of the microscope to do a focusing, and I believe it is focus. Visco. Again, the same principle, remove all the PSS inside the chamber by going right at the opposite end, taking out all the viscoelastic. So, like I was talking, what is the depth that you would like to reach? Correct? It is about 1.5 to 2 times the phaco tip. So this is my phaco tip and it is going down. So I have nearly reached the level that I want to. So I have a perfect range and now I'll try to divide. It is not because it's a soft one.
What is the depth up to which you would like to go to, Dr. Tejas?
See, there are 2 ways it can be done. One is depending on the red reflex that you see. And the second is about 2.5. We can go right up to 2.5.
Yeah. Can you please?
It is not going to break much. Master,
Please center your mic. Yeah, thank you so much.
The patient is going. Sorry for that. Okay, can you go to chop, Mr. Giri? Yes, from Elcon. So I am going to be in a bit of a trouble because I've not been able to chop. For me, it is very important to be able to chop. and create a space. Because as Dr. Purinder pointed out, I did not do a hydro. And if I have not done a hydro, and if I cannot take a pie of the cataract, it's very difficult to rotate the lens, the fitting lens. There is a reflex coming from the ray, I believe. Right? Viscoelastic. So now in this case, since I have not done a good job, I'm going to do a delayed hydro. I did not do the hydro to begin with. Yes. I will do a hydro now. In my own settings, I really don't have to do a hydro dissection in 95% of the patients. But here probably I'm a bit uncomfortable. I'm using machines which are not used to every day. Hydro dissection. Right? I believe people are not sleeping in the hall, right? So this is known as the delayed hydro. उनका सर जा रहा है इस टाइम आप उनको ये साइड पे कर सकते हो तो करके रख सकते हो somebody else बैनर्जी साहब सीधे देखते रहिए राइट में Now I will try to explain why we do not do hydro in almost all the patients with viscoelastic. There are many reasons, or there are many situations where I would not do hydro. The first and foremost is a mature cataract, and especially if the mature, so this is also a lesson learned. The air should not be there in the chamber because it again decreases your visualization, and you spend more time and more viscoelastic trying to remove that. So whenever there is a mature cataract, we do not do a hydro. Whenever there is a small pupil, we do not do a hydro. Whenever there is a very dense cataract, we do not do a hydro. Why? We feel that there is already a lot of stuff inside the bag. Why add more volume? If you are successful in chopping and having the pie of the nucleus, you will have enough space, and if the nucleus does not rotate, you can still do a hydro and after the chopping and eating as a one pie. Being not able to rotate the nucleus is not a good thing. And so I would not advise not to do a hydro in all cases to begin with. सीधा देखते रहिए और बढ़िया Many a times, if the patient has already undergone some intervention from your retina colleague, be very careful, because sometimes they have actually created a small piece here. And if you do a hydro in this type of a patient, there is a chance that the nucleus will drop. So I've been successful in at least rotating the nucleus. I'm still not focused well. Let me try and do it once again. Viscoelastic. सीधा देखते रहिए, correct नहीं डालिए। Viscoelastic. 27 या 24 गेज हो तो अच्छा रहेगा, बहुत टाइट है तो इसको कैरी ना 27 या 24 चाहिए। So these are the situations where we actually don't hydro, and if you are in your regular conditions, you will be very surprised you don't need to actually hydro all the time. Yes, but it is very important when you are learning hydro and rotation of the nucleus is a must. Do not attempt to go inside the eye before you do that. This is only when you have learned the phagometrification. So I'm pushing some viscoelastic also in the bag. I'm trying to create a space, and you can see I can very easily rotate the lens. Sir, आप सर ऐसे रखिए और सीधे देखते रहिए. I'm having some problem focusing here. I think I'll go down. That's better. So I have actually not been able to do a good sculpting. Lens was thicker than I thought. And like I said during Dr. Purina's patient, you need to have at least one crack to be able to do. Because till it is a complete circle, a complete saucer, it becomes difficult for you. So I'm trying to find a plane, a cleavage where I believe I'll be able to do that. The line. So I have to find a wall which is thick. The wall is quite thick here. So I'll try it here. And I have nearly been able to do it. So this is known as a saucerization, which is not a very ideal condition. And now I think I'll be able to create the saucer. Yes. And now the things will become easy. Because you've broken the saucer. Correct? You can see. So you need to be patient to be able to not create the saucer. And if you have by chance created a saucer, you have to deal with it. So line on the cornea, please. Yes. Thank you. So what's happening in the audience? Dr. Balla?
Yeah, Tejas, we are watching it intently. Very nicely done.
Oh, thank you.
Shown us the
I
key.
thought you're all eating lunch.
Yeah, in softer cataracts, you have to be patient.
Yes.
Try to hurry up. Yes, you rightly pointed out. Proper
Somehow I have a bad habit. Youngsters should not be doing this. I try to finish my IA also with my FIPO Pro. I'm just trying to demonstrate a few things, but I will not do that. I'm in an unfamiliar terrain. Viscoelastic.
Because you will not be able to chop these nucleus, softer nucleus consistently in all your cases. So you have to modify your technique.
Absolutely.
Have there's two heminuclei, then your job becomes very easy.
Yes.
Flip the rest heminucleus into the anterior chamber like you have very nicely shown.
Thank you. So the whole idea is that you should be able, there are three important steps once you've done a good REXIS. One is get a good divide, the first divide, IA, irrigation expression. Second is you have to be able to take at least one small piece of the pie or the pizza. If you do that, yeah, that means you have broken the saucer. Continuous. I want a linear. I don't want a. Oh, this is the curved one. I want a straight one. You don't have a straight one. You know, it's straight. Straight है. Do it linear. Oh, no. So, like I said, I have made only one side port because when we were taught in way back in 1990, there were no bimanuals. At that time, there used to be a very big presentation called removing the irrigation, removing the subincisional cortex. That used to be a presentation which we used to give. I'm deliberately not removing this with cortical matter because I want to demonstrate another technique. Uncle, सीधा देखते रहिए मेरी तरफ और बढ़िया.
Dr. Tejas, you always prefer a bent IA probe.
Oh, I have never used a bent IA. I only use a straight one.
Okay.
But adapting to the circumstances, it is elastic.
Very valid points which you demonstrated in.
I'm demonstrating something different now. This is called a dry aspiration. What do? You fill up the chamber. This is very tight. You fill up the chamber with viscoelastic, full to the brim. मेरे को 27 gauge cannula पे 2 cc syringe चाहिए. See, you can also take out many times this cortex with the help of a. Now I'm going to demonstrate. I'm going to demonstrate the technique of dry aspiration. 27 gauge cannula. This is very important in many conditions. The first and foremost, when you do not have a bimanual. So you have filled up the chamber. You go from the second entry or the side port and very easily remove this. Once or twice, when the entire irrigation aspiration failed, we could finish the entire irrigation, the cortex removal with this. And if you see, it's very safe. You can even do a polishing with this. This is so important. When I still remember those days, we were trying to help people in Kutch during the earthquake, and somehow the irrigation aspiration would not work. And we had to finish all the surgeries this way. So, like everybody says, necessity is the mother of invention. And at that time, we did not have bimanuals. So, this is how we used to finish. If you have a PCR, this is the most important method besides the bimanual. In spite of a PCR, you can finish the entire irrigation aspiration without hydrating the vitreous. Can you see? So we can do. I have demonstrated, so I'll finish off with my irrigation aspiration, viscoelastic piece. Which obviously can be made. What time is it? Oops. I am going to implant a panoptics. Again, the Ferrari of lenses. I have a Maybach microscope. I have a Lamborghini of Eco machine and a Ferrari of lenses. Wow. I'm so happy. Thank you, Dr. Kashyap et al. All the Kashyaps have been and Alcon for giving me this opportunity. Right. Yes, please. Any questions? Viscoelastic or lens?
So we welcome you all. Now this is the time of felicitation, and just because we have little less time, so we are doing felicitation in between. So as Dr. Madam is going, so I request the National President of AIOS to felicitate Madam, and along with this our Jharkhand Ophthalmological Society.
Operation, 2 मिनट का काम लेंस डालने का है.
Madam, please.
एकदम बढ़िया हो गया है.
JHOS office bearers, please, please join. Vanati madam, shawl, flower.
This is a special holding process from Elgon.
A small souvenir also. Saw in Hubli. So.
Okay. Usually in my setup, I don't load the lens. I will be struggling a bit. Please bear with me. And I use more of Johnson & Johnson products. So this is also something new for me. So coming to the lens, the PanOptix lens. Basically, it's a trifocal lens and gives a good far distance and near vision.
That's it. Can I call you?
So I also mentioned while Dr. Purinder was operating, I always like a push type of implantation and injections, injected. But sir, ऐसे रखिए पहले सर. अभी 2 मिनट का काम बाकी है, ओके? थोड़ा सा आपको खींचा होगा, पर बैठ कर लीजिए कि लेंस रख रहे हैं. So my second hand is always going to stabilize the globe. You see, I can now move the globe any way I want, so that I don't lose the eye. Even if the patient moves, usually my assistant holds the head. Excellent. This goes to a 2.2 incision, correct? Giri? Yes. And just look at that. It is going like a piece of cake. Very easily. It also opens like a very slow opening. So you're all the time in the world to actually manipulate it. This becomes very important, especially when you have a PCR. Yes, right?
Hello. So, how do you think about live surgery sessions, sir?
Dr. Bharti, I lost your voice. How do you think?
See, rarely I have seen live surgeries being done at annual conferences, but hats off to Bharti that you see not only cataract, SICS, but retina surgery also we saw. This is one of the rare achievements for a state level.
Valve also.
Yeah.
I'm a glaucoma valve.
I thought, Dr. Lalit, you are also encouraging me with your words.
Surgery. Now
This is the slowest surgery I've done in a long time. But I just wanted to demonstrate all the steps. These are all unfamiliar territories.
They are a pretty good learning experiences because you see all the nuances which is when you see on YouTube or when you see the edited versions on the of these videos during our conferences. But here you see how we can, like in my case, we had a stuck IOL. So that stuck IOL, how to manage, how to do it. This can happen with anyone.
Yes.
And how coolly we can do it, how better we can do it to give without any complications, how to manage this. This is the learning experience of this. Nonetheless, the problem is of audiovisual and other things. And if any complication occur, then that is a problem. But definitely, these are much better learning tool as compared to the YouTube or the edited versions which we see during the conferences.
Excellent. I'll just try to magnify and show you the PanOptix. It has 22 rings.
What Tejas has shown, believe me, it's one of the very good teaching exercises he has done here.
Oh, at last, the president speaks. Thank you, sir.
It's not a question of thanks, but you have done.
Yes, sir.
Believe me, what teaching live surgery can do, edited videos cannot do. Because you watch surgeon, whether he is having palpitations, perspiration, kya ho raha hai usko? What he, because he is operating in a foreign setup also. And then also most of them are doing excellent job. You see what Tejas is showing, you can see this video here. Excellent surgery done. Believe me, he must be fantastic surgeon.
Well, thank you. I tried teaching and sharing whatever I do.
But
I hope everybody enjoyed.
this training, this learning has a great value.
Yes, in fact, I was very happy and I was very honored because I had a teacher like Dr. Vasada. I believe everybody knows.
Have to be very vigilant, very careful watching here, and not hesitate to ask any question.
Yes, please go ahead.
Want to learn more.
Except for my bank balance, you can ask any question, sir.
And I request Honorable AIOS President to just felicitate with flowers and shawl, bouquet and shawl, and there will be a double felicitation there also. So you are a discussant here. Dr. J.S. Bhalla का नहीं है नाम? किसका? Dr. Gopal Pillai. I request Honorable AIOS President to felicitate Dr. Gopal Pillai. Double felicitation will be there. There also. Dr. Bhalla का? Dr. Bhalla? एक और shawl और
साइड में भी ले लेना
Sir, AIOS President sir, please felicitate Dr. Bhalla sir. Sir, double felicitation वहां भी होगा. भल्ला तो भल्ला. एक Sir, our some of the faculties who are operating, they are not here, and we are doing some of the Dr. BNR Subudhi has come, so we want to felicitate Dr. BNR Subudhi sir. Flowers and bouquet and shawl. Subudhi sir is the ISOC leader, great ISOC leader. We welcome clapping. Flower.
Hello? Hello, am I audible from OT2?
Yes, you are audible.
Okay, till our IPC, till our KK patient is getting ready, we will be briefly showing the glaucoma valve surgery. Dr. Manish is here.
Honorable AIOS President, to felicitate Dr. Rajiv Gupta sir, because sir, you as per your directive, you told us in MC meeting so many times that JHOS and all the state societies, they have to do monthly activities for PG training, wet labs, public awareness. So they all have done this. We have created a JHOS Excellence Award this time for contribution in those fields. So Dr. Rajiv Gupta sir is getting 2 awards, JHOS Excellence Award for RIMS Ranchi, and another is his personal award. So for JHOS Excellence Award RIMS Ranchi, I invite other JHOS RIMS Ranchi people, Dr. Rahul and Dr. Deepak Lakra, who are here. JHOS Excellence Award. Yes. No, ये आपको मिल रहा है, ये आपका personal. This is your first. हाँ? रिम्स एक राजीव गुप्ता सर का पर्सनल है. रिम्स रांची का डॉक्टर राहुल. अच्छा, now you have come after operating. Yes, Dr. Anirudh Maiti. So sir, this is the JHOS Excellence Award. Sir, देखिए तो जरा.
अरे भाई बाद में ठीक हो जाएगा.
रिम्स के बाकी लोग कहाँ गए? अरे रिम्स के बाकी लोग राहुल है ना. अच्छा ठीक है, चलिए. Okay, RIMS Ranchi. This is the institution award. No. There are 3 PG institutions. So the second is CCL. The head has not come. Third is she will come. Second is in between. Dr. Anirudh Mathi has come from OT. So shawl and flowers for Dr. Anirudh Maiti. Dr. Anirudh Maiti, we welcome you, and I highly appreciate him in the last moment when Dr. Rupakanti Biswas has issues, not able to come because of his father's sickness. He came in the last moment. So thank you so much. अरे यार जाओ, हमें चले जाओ, हम चले चलो हाँ राइट एंगल में लो भाई. And the second JHOS Excellence Award is to Kashyap Memorial Eye Hospital, Dr. BP Kashyap. Your institution means क्या बोले?
देखो रियल बात तो उसने बोल दिया.
क्या सर मेमेंटो दो, because we have done. Because क्या है कि कश्यप ने भी बहुत एक्टिविटी की है, monthly activity, which our AIOS president told us in every MC meeting.
Bharti, the reason is Bharti, the reason is, you see, one of the motto of AIOS is to do all this PG teaching and disseminate ophthalmology in every nook and corner. And that's the reason in my address, I thought that, we should have a state-wise competition, like BNR keeps sending.
Yes.
You see, aim is to percolate that. My mission is that ophthalmology, har jagah same hi ho. We should not have only metropolis, Delhi, Bombay, Calcutta, but everywhere it should be same.
Sir, but
And therefore, I admire this young lady. So that she has taken a bold step that instead of doing in a capital city, dur jaake conference kar rahe. And therefore, I also prefer this place rather than going to other parallel conferences. You see, aim is to go remote place rather than going to Bombay, Jaipur, or.
Dr. Rajiv Gupta का दूसरा अवार्ड. Dr. Rajiv Gupta का दूसरा अवार्ड. Dr. Rajiv Gupta clapping because of maximum PG students contribution in an annual conference. Maximum PG. Professor Rajiv Gupta. Shawl. छोड़ दो छोड़. चलो. Clapping by public awareness. Dr. Vinay Gupta. They have done a lot of public awareness on glaucoma, on diabetic retinopathy, cataract, eye donation. Dr. Vinay Gupta. Memento and shawl. JHOS Excellence Award we have created because every time Lalit Verma sir used to say, and I used to get panic attack, how I will inspire all the JHOS members for monthly activities. Every month I am just stressing them कि आप ये करो वो करो. ये कह रहे हैं कि ये हमेशा पोस्ट करते रहती है, ये करो वो करो.
The reason I wanted public awareness to be the theme of everybody is because till the time public knows about these diseases, they won't come to you. Especially true for glaucoma, especially true for diabetic retinopathy, ARMD. These people have to come early, and hence the relevance of public education and awareness.
I think Dr. Rashi Shyam has done a lot of teaching and public awareness. She is in OT. So I called Dr. Vivek Kedia. He has got 2 awards, one in Kushalpalli and one in Ranchi for the public awareness and the teaching. Public awareness and teaching. And he is one of the best organizing secretary. Last time he was organizing secretary and I had less stress. Can you see Dr. Tejas Shah? Has he come from OT? Dr. Kudlu and Dr. Tejas Shah? तो अभी सर अभी बहुत ही अच्छा हुआ कि सर्जरी चलते चलते हम लोगों ने ये कर दिया और 2 लोगों का बचा हुआ है सर, 2-3 लोगों का. तो ओटी में कुछ लोग हैं उनका बचा हुआ है तो वो हो जाएगा. सर बैठिए. हाँ लाइट ऑफ। हाँ हाँ करवा दे। कौन लोग सब लोग आ गए तो तुम लोग बाहर चलो, हम लाते हैं सब लोग को। कहाँ पे? यहाँ नहीं ठीक रहेगा, बाहर में करते बेटा, यहाँ ठीक नहीं रहेगा। यहाँ पे बाहर
Dr. Bharti madam, are we live?
पांडे किधर है? ओटी में आप यही रही डॉक्टर कश्यप।
Marking.
We are in OT3.
Just to go up. Light, please see the light. See the light. Marking eyes.
Dr. Nidhi, who is operating?
So we are here in OT2.
Good afternoon. Good news from.
Sir, he is being shared.
We are shifting to OT3 to Dr. Kudlu right now, and we'll come back to this OT again.
Okay, Dr. Kudlu is OT number 2.
Yes. Yeah, hello, sir.
Yes, sir. Yes, sir.
This is Dr. Vibhuti Kashyap from OT3, and we have with us right now Dr. Krishna Prasad Kudlu from Prasad Netralaya ODP, a place very, very close to me. And he'll be performing a toric IPCL, and I'll be handing over the mic to Dr. Pooja, who will be coordinating the surgery for him. Dr. Pooja.
Thank you, sir.
You are live. Thank you so much. Good couples have done the videos from Manipur. Even our professor such a wonderful, it reminds me the real, I think I can say the hard work what has put to make this institute into a different level, the place has gone to. So, before that, I to come as a faculty sir for this opportunity. So I'm just going to mark this
Going to mark the toricity of the IPCL. Correct the audio. OT number 3. Please, somebody correct it. Please switch off other the OTs and please close the door. Yes, Dr. Kudlu. Yeah, you have made the access now.
See, all know that what are the this wrong. Actually rejected case with a high refractor. So high refractor basically this it does
Please somebody take care of the audio. Please somebody take care of the audio from in OT number 3.
Can you able to hear me? Am I audible, Chief?
Now is better.
Yeah, I'm gonna shift this mic nearer to Kudlu, sir, for a better audio experience. Please. So the just for a double check, already this microscope is assessed with the Varion. Still, I think Dr. Pooja has done the marking, bubble marking in front of the slit lamp. We both cross-checked. The lens has to be placed at 65 degree. So basically, this bubble marker, because most of the people, those are practicing, I want every cataract surgeon has to start refractive surgery. If they want to start a refractive surgery, the best platform to start a phakic IOL. because these lenses, as I said, that you will get between a refractory error of -3 to -23 diopters. In astigmatism, you get brighter IPL flaking at the range of -5 to -23, even at the range of 5 cylinders. The advantage of this lens in spherical will have a 6.5 overall diameter. In toric, they have a diameter between 4.65 to 5.25 diameter. So let me start the surgery once again and come back to the lens specification in the end of the surgery. So, no, side port.
Please bring the mic little more closer to him.
Lalit sir, can you hear me?
Yeah.
I'm doing the side port. So I'll do only one side port. Paracan or any.
You prefer the lancet knife for the side port, or you don't use the MVR blade for that, sir?
Yeah.
Okay.
Intracameral Phenochem plus. Phenochem plus. Yeah. Thank you so much. Sir, you are asking actually this side port, actually I always use something called MUR blade, what retina surgeon uses. But since whatever the availability in that particular OT, I normally do it like that. So this okay with that. The side port was pretty good. After entry, I'll go inside, put a viscoelastic. You have to be very careful. These are phakic lenses. While putting the viscoelastic, fill the antechamber. Aram Shama, nothing will happen. Don't worry. So you could able to see the nice entry 2.8. So I'm doing a 3-planar incision 2.8. If this is the first incision, I'm going in and I'm dipping inside. So always when I'm doing in phakic lenses, slightly I extend my inner wall just because of the easier in the implantation. Now I am going to load the lens. Basically hydrophilic lenses. See, we have got hydrophilic lenses in this phakic platform. Then you have got polymer lens also. But these all lenses are hydrophilic only. The only difference is some of the lenses are coming with a polymer coated. But the end result is the one and the same, cartridge. McPherson forces. I want to focus the lens. Can you able to see the cartridge very well?
Yes, we can see the cartridge.
Can you give me the lens? Lens. This way. This way. So can you able to see the lens?
Yes, we can see the lens.
Always you should look for the holes. The leading holes has to be on your left side and the trailing hole has to be on your right side. Now I am putting within the cartridge while pressing. Keep press your left hand also. This is very, very important. Make sure that it will not turn ulta while you inject the lens. The line over the cornea.
Do you recheck the lens when you push the cartridge?
Yeah. I rechecked actually in this patient.
Okay.
After rechecking only, now I am going ahead with the implantation.
Very nice.
See, unlike the other lenses, these lenses are quite actually hydrophilic lenses are pretty good. So I'm just going inside. Go with the smooth, gently movements. This is very important. I'm at the wound only. I'm pushing. You could be able to see lens is opening it very, very nicely. and done. I think you could able to see the perfect injecting of these phakic lenses. As I already told, these lenses for beginners, I have trained more than 100+ doctors under the biotech platform. Actually, we are the first person to design these lenses, even in a small place called Udupi. I think Lalit sir also visited my place couple of times. There, or Tucker. So we get these lenses, water content is around 20 saline on the over the cornea. So normally while injecting only, it has gone behind the iris. Something that happened unintentionally, but it is good for the patient. Now for the leading trailing haptic, I always use main port. Make sure that it will be tucked under. So this port. These surgeries are very simple, but each and small steps like how you do entry, what you do, paracentesis, very, very important. Also, injecting the viscoelastic over the lens is very, very important. Once again, I'm very much happy with the microscope, what Alcon has provided us. Fantastic microscope. Thankful to the guys actually helping me. Alcon is always like that. They make the surgeon more comfortable. So now I am trying to dial these lens exactly where I have marked.
The digital mark.
Yeah. I think you could able to see the marking which is parallel to the. Are you able to see?
Yes, very clearly. And
yeah, perfect toric marker. But I want to double cross check with the initial marking what Dr. Pooja has done. So as I said that these lenses, I think we have done nearly around 500 lens implantation with the biotech, both toric and the regular one. The results are phenomenal. Why I'm telling you, patients, the range of power -5 to -23, and cylinder at the up to 5 cylinders. So you can correct almost -28 diopters, which is not there in any of the other lenses available in the market. And if you see, even the lens thickness is also quite close to the any competitive brand. See, I'm just telling you, near 1,000 lenses, not even a single complication patient has come to me for any of the with the any cataract except for one, that is patient had some other underlying factor. Patient had a very high diabetes. Apart from that, not a single lens I had explanted. Shall I? This one, shall I? See, always. I'm doing simple. Okay. So always I tell all my phakic training, stay within the anterior chamber for a period of 1 minute. You have to remove all the viscose. This is the key point behind the success of phakic lenses. See, I think there is no financial interest in this product, but what I just wanted to share, all product, whether it's a trifocal, I think most of my friends do agree. Any of these lenses, I think from biotech, everything is very, very good. I think the best Indian product, I think Make in India policy of Prime Minister Narendra Modi, they are making it in Ahmedabad. And these lenses are very good, results are pretty good, because the advantage of phakic lenses, which is placed near to the nodal point of the eye, so normally the vision will be better than the promised, and also you will not be touching the cornea, so the overall contour of the corneal contour will be remain normal, and also contributing towards the dry eye. The chances of dry eye with these lenses are with the phakic lenses are much lesser. So just before, I think I want to cross check the overall whether the lens is exactly in the 65 degree, and in the end I will close 1 minute. Okay, can you give me the marker one more time? Right there.
Dr. Kudlu, what do you do to remove the visco from behind the lens? Do you do that? Do you try that, or it happens automatically?
Like, see, you could be able to see Behind the lens, I'm not going with the phakic lens because if I touch the crystalline lens, the chance of developing a cataract. So what I do, see, normally I put a phenacan place so that you can see if pupil is fully dilated. So whatever the visco is there underneath the lens, it will come on top and it will go back. But we don't go underneath the lens. And even from the center hole also, the remaining visco will come out. So the advantage of having, only thing is you have to maintain that full dilatation. If you keep fully dilated cornea, I don't think so it's going to have any problem. And probably even our studies, I think only out of 1,000 patients, only around 8 patients had an initial hike in the intraocular pressure, then we were controlled with the anti-glaucoma. But results, especially toric lens, none of my patients actually had even 0.5 cylinder is also remaining. So I'm just checking here. I think it is 65 degree. Zero, 180 and 65 degree. Yeah, slightly I will put it down. Simple.
One of the disadvantage of fully dilating the pupil is sometimes, you are unable to see whether the haptics has gone behind the iris or not.
Yeah, but always look for a round pupil, sir. That is very important. Look for a round pupil. So I'm just dialing a bit so that make sure that the other advantage, sir, like these lenses, what we do in car, actually they tell that you cannot touch the center part of the lens. But since it is a hydrophilic lens, you can touch, sir. There is no problem. So I'm just trying to be like after I see, I know how much has to be rotated, slightly rotating a bit, make sure that exactly it is 65 degrees. I thank actually Biotech for also helping me out today morning. He was waiting there in the airport. Once again, I thank Bharti TV and BP Kashyap sir calling me all the way. And I am inviting you whole family to Manipal. I already told Vibhuti. Vibhuti said that he is coming for state conference. He said that Manipal is like his second hometown. He wants to come 2024 conference, which is I am going to do in place Manipal. And I invite all my friends from actually Jharkhand, because why I'm telling you, I'm originally from Haryana. Actually, our family moved to Jharkhand and finally we settled in Karnataka. So I got this like a sort of a second citizen of Jharkhand. So always I got love and affection towards Jharkhand. Also, our Swamiji is also living near to this place only. So once again, I thank, and in the end, one small request for all my friends that I'm standing for editor proceeding. If you can all help me, definitely I'm ready to do any kind of service towards you. Thank you, one and all.
Definitely, sir. Definitely. Thank you very much. Thank you very much.
Alright, so we will be shifting from OT3 to OT2 to see the proceedings, the AGV. Dr. Nidhi, over to you. Please stop sharing for you for OT3. Thank you.
Good afternoon, everyone. Now, I hope you're getting the live feed from OT2.
This is not the glaucoma valve.
Yeah, I hope everyone can hear me.
Yes, you are clear and audible.
Okay, so Dr. Manish Pandey is operating on a 35-year-old female. She has inflammatory glaucoma both eyes. She has been operated for trap with mitomycin C in both eyes 5 to 6 years back. Right eye is all right now with pressures of 10 with one trap done. Left eye, it is a good diffuse working bleb, but over the past 4 years, her anti-glaucoma medication has risen up to 4 drugs. So currently she is on brimonidine, dorzolamide, latanoprost and timolol combination. And her pressures are between 24, 25, comes down to 20, but not less than that. And apart from that, she has now a remnant temporal eyelid with 0.9 cup in that eye. So the decision has been taken to do AGV implants for her in this eye, left eye. And it is over to Dr. Manish after this.
So you can see that the bleb is there superiorly,
And I've opened up the conjunctiva temporally. And you can see one of the sutures there. One option is to take a superior rectus bridal suture, which was a little difficult. So I've taken a clear corneal traction. And can you just give me one forceps? And I've passed one of the sutures, and we are just waiting for the valve to be open. And it's around 8 millimeters behind the limbus that the suture has been passed into the partial thickness sclera. Now we'll pass the second suture. Before that, we have to prime the valve, and then we'll proceed accordingly. So I'm opening up the Ahmed valve. Ahmed valve comes in FP7 and FP8 varieties. The FP7 is what is the adult variety, and we'll use it. The FP8 would be the pediatric one. So I'm just opening up the Ahmed valve. So this will be the Ahmed valve, and this is the valve assembly, how it is there, if you are able to see. So this is a plate, this is the valve mechanism, and this is the tube. So first thing that we need to do, and you can see some holes there. So this is basically for the fixation of the valve after a few months of surgery. First thing we need to do is to prime the valve or push some saline into the valve to see whether the valve is functioning properly or not. So I'm taking some saline on a 27 gauge needle and trying to push it through the lumen of the valve. What you'll be able to see is some amount of fluid egress from this side. I'm not sure if you're able to see it there. So I'm opening up I'm putting and I'll push some saline there. You can see the saline going there, and you will be able to see the egress of the fluid from the other side.
Yes, quite visible, yeah.
But as you can see, I'm using a lot of force. I'm not able to see a very proper amount of fluid egress, what I should see in this sort of a valve. I'm applying a lot of pressure, so we need to prime the valve to see whether it is functioning properly or not, which I'm not able to assess it at this point because I'm using a lot of force to push it. I'm not happy with the valve mechanism as of now. And that's always the reason that we need to keep a standby valve, find out whether we need to change the valve at this point or use a different strategy altogether. So I'll just try to use it once more and see whether it is functioning properly or not. You can see it's a little better, and you can be able to see the movement of the fluid from that side, right? Not too much of fluid because it's going to damage the mechanism of the valve. So I pass one of the sutures. I'll just keep talking in between.
So Dr. Manish is operating in the superotemporal quadrant. There is a wide diffuse bleb superiorly. He's already put stay sutures.
So I'm passing this needle tip from one of the.
What sutures are these?
This is 80 nylon. Some people use 90 nylon also. I prefer an 80.
Dr. Rashi, what sutures are these?
80
nylon, sir.
Passing it through one of the holes here, as you can see, taking it out. I'm now passing it through the second one. These are basically for anchorage of this plate initially. Over a course of time, the holes what you can see on the plate on the back side are going to fixate the valve altogether. So this is only for the initial part, the valve does not move from a certain position. Second suture which I have placed. Now I have to put the valve inside. Give me one take also call it. Straight colors. Just straight. I'll be putting the valve inside. So be careful not to touch this area of the valve, which is the valve mechanism. So this can, I'm putting the valve inside. It could possibly.
Recess for the reach. The tableau opening. Okay or not? Sit inside.
That is beautifully done despite the fact that we have very less exposure in this eye. Superior, there is a bleb. So superior rectus stay sutures could not be put and corneal sutures are there. But still exposure is a little less. So it is difficult to have good exposure of the superior temporal quadrant. But Dr. Manish has done it very nicely. And the valve is in place now. And then he is going to suture it.
There are the two ends there. So I have not removed any of them because there is sometimes the slippage of the valve posteriorly. So keeping them for aligned also.
What is the distance between the from the limbus to the first stage?
8 millimeters. 8 millimeters. 8 millimeters.
Around 8 millimeters, sir.
Okay.
पुश कर रहा हूँ पेन को से गरम ठीक है दूसरा वाला अब This is around 8 millimeters. Push it a little more posteriorly. Left side. स्कूल में यहाँ पे कम करो यहाँ से थोड़ा सा ट्रैक करो और यहाँ ऐसे पुल करो
एक्टिविटी बहुत डराता है हम लोग को सर बिकॉज सब लोग जॉस वेबिनार तो कर लेते हैं बाकी पढ़ाई लिखाई कर लेते हैं अलग अलग जगह कॉन्फ्रेंस में हम चले जाते हैं भाषण देके आ जाते हैं लेकिन ये जो मंथली ये सॉफ्ट कॉपी भेज देंगे मेरी सेक्रेटरी तुरंत भेज देगी आपको सर नहीं ये मंथली एक्टिविटी नहीं भेजे हैं वो ये भी आ गया है नहीं सर वो ग्लिम्स है जो मैं भेज हूँ वो एक ग्लिम्स है हाँ मैं मुझे पता है ट्रेलर भेजा है ग्लिम्स भेजा है ये फुल है ये एक्टिविटी प्रेमलता ये बड़ा वाला जो फाइल है ये बड़ा वाला इसको झॉस में भी डालो अभी नहीं छोटो मेरा मोबाइल खुला रहता है इसमें मोबाइल इसके I request Honorable AIOS President to felicitate Central Coalfield team for great monthly activities. They have done great job, sir. और सबसे बड़ी बात है सर हमने इनको बोला कि हाँ ताली बजाओ भाई आ जाओ हमने बोला कि सर कि डेट लगा के करो सबसे ज्यादा इसने फॉलो किया है सबसे ज्यादा डेट और बैनर और मुझे ये डर लग रहा है कि हमारी सीनियर भी है सर 3 साल सीनियर है हमारी रिम्स में आप बताइए सर रिटायर कर जाएगी 2 साल है 2 साल सीनियर है सर जाएगी रिटायर कर जाएगी तो मेरा कौन काम करेगा
हेलो कैन यू हियर अस फ्रॉम OT3
सुबुद्धि सर आइए
हेलो या
Dr. Harbansh sir is going to show us a very important step of how to do the toric marking. We are going to show this with the external camera.
Sure.
Madam, XCCL, please.
Just give it to
तो कितना बढ़िया.
So mic लगा दो यार. अच्छा ठीक है. So what are, though they have got the availability of the Varion, okay, but can you hear me?
Yes, sir. Yes, sir. Loud and clear. Please go ahead. Yeah.
So most of the time we may not have the Varion, and most of the people in the world will not have the Varion. And they are good enough studies, just all and above 10 years. So over there, the difference between the manual marking and this marking was only 2 degrees of misalignment. Toss दिखाओ. So you can mark, दोनों आँख खोल लीजिए और मेरे को देखिए, मेरी नाक को देखते रहिए. Just by simple and just make a mental picture where the 6 o'clock is. मेरे को देखते रहिए, मेरी आँख पे देखो, and then just mark it there. Now this is not 6 o'clock or 90 degree. This you should consider as a reference point. Now make your mental image where the exact 6 o'clock would be. If you see this, see from different angles. मेरे को देखते रहो. See from this side. See from this side. And then you decide whether the 6 o'clock is just at the mark, a little temporal to the mark, or nasal to the mark. So this mark seems little on the temporal side. So exact 6 o'clock will be on the nasal side of this mark, or just little more on the nasal side. After this marking, we make the patient lie down. Okay. And I take the gloves now. Let out. Now you can go back like that. Now you can take the signal from the another OT. Meanwhile, we take the and clean the patient.
OT number 3.
Passing the second suture now through the plate. Triangle process. So this is the second 80 nylon that we have passed. This is the first one. So the valve plate is now secure. Now we'll proceed to the further steps of the surgery. So now we have to so this is the tube. Now we have to cut the tube to an approximate length of what we want to be the anterior chamber. And then we have to make an entry somewhere here. Cover this area of the tube for the tube with some sort of overlying sclera or corneal tissue that is available. Level up.
अब 2 लोग बचा लाओ. राशि शाह, मनीष पांडे. मनीष पांडे तो लगाओ, बोल लगाओ, बोल लगाओ, मनीष पांडे, सुगत
Concept is not to throw up this tube in, because sometimes may require it till the surgery is done.
तेजस सा हो गया, वीना सुबुद्धि
So now we proceed with the placement of the tube. चाहिए 4 gauge का needle.
Consider that that length of tube is enough and not long and not short.
Yes. Find out where we need to place it. The pseudothetic eye, so there are both options. Sometimes you have to put it into the anterior chamber, and one option is to put it sometimes into the sulcus. Right? So usually recommended is to use a 23 gauge needle. What I'm using is a 24, is a little smaller gauge needle. So it is going to give me a little struggle to put the tube, and that struggle is fruitful because I don't want the hypotony to become a problem in the post-operative period.
So this is 1 millimeter away from limbus.
This is 24 gauge. Trying to enter, you may be able to see the needle tip into the anterior chamber there. Trying to come out now.
Me? Dr. Manish, can you hear us in the OT?
I'm not able to hear. What is it?
Can you repeat the question, sir?
So how do you measure the length? How do you find out the length to be trimmed and to be kept in the anterior chamber?
Usually it's around 2 to 3 meters. I don't want it too big or too thin, but the length of the tube is a factor that is in the surgeon's hands. So if I'm putting it into the sulcus, I'll put it a little longer tube. So if I'm putting into the anterior chamber, I'll put it a little smaller tube. So that is the reason why the tube is so big. Sometimes you're putting into the vitreous cavity, you may require a much longer tube at this point. So at this point, I think this much of tube is more than enough for me, because it's not going to get, I can see the tube, it's not going to get obstructed. I'm putting it very next to the cornea, and I must have noticed I've put the bevel up so that it does not get obstructed with the iris tissue which is lying behind. So since the tube recommended is 23, I've used a 24. I'm having a little struggle to put it inside.
Yeah.
Yes, then yes.
Is it visible in the anterior chamber?
No, still not. No.
Still not. Tip is not.
Yes, yes. Possible.
If there is vitreous in the anterior chamber, what do you do?
You might be able to see the tube tip now into the anterior chamber.
Yeah. Yeah.
Vitreous in the anterior chamber, it's difficult. You'll not be able to put it because vitreous is going to block it. You need to do a vitrectomy also at that point. If you want to put it. I hope you may be able to see the tube tip now into the anterior chamber. Here.
This is Appasamy microscope. That red reflex, if we can see. If we have red reflex, then I think we will.
Yes, it's an upper microscope.
So if we can have the red reflex, I think then we will be able to see the contrast of the tube better. Now I think it is visible. It is fairly in the anterior chamber, almost 1.5 millimeter it is in the anterior chamber from the limbus.
Now, tube length is a little more than what I want, but this is okay. Now I have to fixate the tube now.
Dr. Manish, can you show the forceps that are used to handle the tube? These are special forceps, not the usual tooth forceps or plain forceps that we have.
Grooves there. This one and this side. This is to hold the tube so that, and you have to push it inside. You can see the hole there.
Okay, okay.
So hold the tube and push it inside. This is given by the company.
Groove to accommodate the tube in it.
So that covers a part of the tube and the plate placements. Now we have
two jobs: to secure the tube and to cover the tubes.
So you will fixate the tube and
Yes, I'll fixate the tube first.
you will be fixating it with what suture?
80, this is same 80 nylon.
80 nylon. Okay.
Right. We will follow. So this is the silicon model of the Ahmed valve. We have a lot of valves actually. This is a
what
sort of valve assemblies are there. So what I am using is a valve implant. So there are those that are non-valve. They come in different names. The original one was Bowitz, but now we have the Adi as an alternative.
What is the advantage of valve here?
Advantage of valve here because we have to do a second surgery. You can see the bleb is quite big and scarred here in this area. Very little space was available. One option is to do a retrabectomy, and the other option is to have a Ahmed valve. Since the amount of scarring was little more, we prefer to do a valve in this area. But one option is to do probably, if you can, possibly a retrap can be attempted in certain situations. So I've secured the tube to a certain extent. You can see a little amount of elevation there. And now my purpose is to cover this part of the tube. The part of the tube cannot be left exposed because it's going likely to cause an erosion of the overlying connectiva. So we need to cover it with some sort of overlying tissue, which I usually prefer as sclera or a corneoscleral rim if it is available. Sometimes I use a corneal tissue in case it is not available it's not useful for an optical purpose. That also can be used. Sometimes I use a leftover DSEC material if it is available. We have done a DSEC and the leftover cornea can also be used. So there's a post PK tissue, I believe, and you can see a little amount of corneal tissue, and you can see a amount of scleral tissue. You need to put this. So I'm taking a little amount of glue also, need to resize this and place it accordingly.
This is slightly bigger, I suppose.
Bigger, yeah. So I have to trim it a little. Just
preserved sclera. So this is a glycerin preserved sclera?
No, this is not glycerin preserved. Glycerin preserved would be harder, I believe. I'm not a corneal surgeon. That's what I was told. I didn't want to use it.
So this is
glycerin preserved. The other one, the sclera that was there.
The rim was fresh. This one is glycerin preserved.
This is a glycerin preserved, no? Dr. Nidhi will be better, I think, to give us the.
Yeah, so this is the residual rim taken after, I think, maybe an optical keratoplasty was done in this case. And the corneoscleral rim preserved in glycerin has been taken. So, sir wanted a little bit of sclera as well as corneal tissue.
I prefer cornea if it is available.
Okay.
So it will be a cosmetically good result because the corneal tissue, the sclera would look as a white patch sometimes. So that is one reason I prefer it. But in case it is not available, I don't use it. What I usually do is I push the corneal side towards this end so that this area remains much more cosmetically better and the scleral rim can be on the back side. It's still a little longer, bigger than what I expected to be, and just trim it on the back. So it's important not to leave the.
Tomorrow we'll meet certain. So, what is the say? The tube should be covered completely with the preserved sclera.
Yes, some sort of covering is required. Whether it's sclera or something else. Mark for this. Mark for this. Not made any sort of side entry at this point.
Dr. Manish, can you tell us why this sclera is required?
Because if you leave the tube and cover the conjunctiva over the course of few months or years, it's going to erode the conjunctiva.
So the
And
tube.
that causes a tube erosion, and then you have to explant the valve. That becomes a problem. So you always need to cover it. See, there are a lot of things that are available. Even pericardial grafts are there. What we use here is a sclera. We can use a cornea. Some sort of good covering is required.
So this will prevent the
exposure.
Not the conjunctiva, overlying conjunctiva.
Yes.
No,
No, it's very. It's going to get solved, I believe. You are more of a corneal surgeon. I don't know too much about it. But basically, it's a very thin sort of covering. Which is
So you
going to-
don't suture it. You are using glue for this.
Yeah, glue is being used, sir.
What time you are using? Today it's very fast.
This is fibrin glue.
तो बोला कि नहीं बहुत खेले अभी अभिजीत प्लीज कम दो खाना
Yes, sir.
कश्यप
So nice. What are you doing?
glaucoma surgeons, we never rely on glue. Sometimes I put a suture also to be very sure that everything is fine. Usually it is not required. Let's see whether the graft is going to stay, not going to move. I'll leave it like that. So the corneal surgeon is telling me that leave it, not going to move anywhere. So take a words. No, I'm asking.
She's saying put a suture.
Put a suture.
Yeah.
It's going to move. The corneal surgeon is telling me put a suture. Don't rely on this glue. So we can't do it. Give me a suture. Take it. Yeah, you can stitch it under. I just have to close the conjunctiva now.
Okay, so thank you, Dr. Manish, for an excellent surgery. We are shifting the live feed to the second OT now, and sir will be closing the conjunctival flap after putting stay sutures on the patch graft. Thank you.
Thank you. Fantastic surgery, Dr. Manish. We learned a lot of things. We learned the length of the tube. We learned how to put the sclera, how to measure it, and all this kind of stitches.
Thank you for the opportunity.
Fantastic.
So, Dr. Bibi,
Yeah. Yeah. Yes, sir. Yeah. Your microscopic view is there.
Yeah, so I'm going to start. So we had made a 6 o'clock marking. So what we do is that after that, as we thought that if mark my 90 degrees slightly onto the nasal side, you can see I kept the 90 degree on the nasal side. Then I mark 5 degree. I normally mark with the chopper, and then on this I put on an ink mark. Okay, so the why I chose 5 degree on the side mark. See, on the IOL master, the degree was 2 degree was steep. This is the V-lens. And on eye trace also it was 2 degree. On the Varion it was 10 degree. So I thought because there is a good agreement between the two instruments, eye trace and the IOL master, so that is most likely to be accurate. The tunnel is little longer, so I'll make it little wider over here. Outside, inside remains the same. So this is Pinocan. So this is the Pinocan, which will anesthetize the iris also. And this patient is what? ये दवाई थोड़ी सी लगती है फिर आँख अंदर तक शुरू हो जाए. So this is methyl cellulose. So I go to the opposite pole, start injecting there, and
so that there is no mixing of the aqueous with the viscoelastic, and keep the eyeball pressurized. This patient is highly myopic. Eyeball power is 9. Main focus. 9 diopter. So initially you can have little high pressure so that you can make a good incision. And these Alcon knives are fantastic, but only thing they are more expensive now. I think they are costing around 600 something nowadays. Earlier it was around 400. But you can ETO them and can use it for 5-6 cases very comfortably. We can increase the light for excellent. Now we can lower the pressure because we need to keep the, it is not the IOP, it is the how the capsule is placed. And then on the left of the center, we make a small nick and lift it up. Yes, I like viscoelastic. Normally I take this needle on a viscoelastic syringe so that I can inject if there is a shallowing of the chamber. To spread out the capsule and then slowly and slowly try to bring it in. Normally I use 2 cc syringe for the hydro. This operating microscope is actually super. We are operating at how much illumination? 24%. Huh? 27. So it is just 27% of the illumination. Light पे देखो माता जी, बत्ती में देखो, हाँ बहुत अच्छा. Bottom line थोड़ी सी कम रखिए, बायोपिक है, इसका अभी आपको थोड़ा सा खिंचाव लगेगा, वो पीछे कुर्सी पे ध्यान रखना है, कुर्सी पीछे नहीं कर जाएगी। लाइट पे देखो, कंटिन्यूस इरिगेशन ऑन करो। जब भी मेरा कोई भी इंस्ट्रूमेंट अंदर हो, कंटिन्यूस इरिगेशन होता है। So this is a high myo. So we can now I'm home sitting here. 500. Is operating microscope, the view is over there focused. Focus, man.
So do you find any difference in a very, very high myopia cases and normal cases?
Normally it should go well, because the only thing is that because of the deep chamber, at times stitching becomes little difficult.
I can see that you're going almost vertical. Your probe, the probe of the tissue is almost vertical.
Yeah. So that's the problem of the having high mark. So is the view over there focused? But then whenever you are getting a very hard cataract, then myopes are better because you get good chamber depth as compared to hypros. Have useful last street. Pencilos. Pencil. This I doing toric IOL, you don't have to have very on, you don't have any special equipment, because there are many studies to prove that manual marking, whether it's a bubble marker, slit-lamp marker, or just make the patient sit and do, there's not much of a difference. And more than 10 degree of misalignment is very, very rare. Continuous, please.
Very nice tip, sir. Very nice tip.
So I call it modified bimanual. They have made only one side port incision, but these two instruments are separated and using it as a bimanual. This operating microscope illumination is fantastic. We are going to use the toric panoptics in this patient. You can see little this now we got the posterior capsule, but there was no tear. If you catch the posterior capsule and if you don't move your hand, the tear will not take place. But if you remove suddenly, tear will take place. In fact, I tell my residents, right, बेटा ये वापस ले लो सर, इसको होल्ड करो, मेरे को मिठाई से दो दे. I do not allow the chamber to collapse in any stage of my surgery. And it's very, very important for the diabetics and high myopes, so that there is least chance of scanning and least disturbance to the picture space. Yes. Okay.
So you had inserted both the irrigation aspiration probe, both the probes from the main incision?
Yeah. Just only side ports of incision, because I don't want to discard this wound over here.
Okay.
So when you do from irrigation, I put the irrigation from here and keep the cannula oblique so that there is no leakage from here. And this all can be removed very easily, but only this part I remove with from the both the cannulas from the side port. The panoptics lenses are very good whenever patient needs the near, intermediate, and distance vision. But for those who don't need that much of a near vision, then the Vivity lens is superb actually. I have started using Vivity a lot more, though I got a tie-up with the Johnson & Johnson, but still I prefer Vivity so much that I started using them a lot. Because again I was much more happy with the Symphony because of the least glare and halos out of the all multifocal EDOF lenses available. But Vivity is a step better than that, because you don't want patients complaining about anything. Infusion or candle. And once I go in, they will put it in continuous. So I usually prefer to do the hydroimplantation in all my cases, particularly the toric IULs are very important to do the either the hydroimplantation or use the sodium hyaluronate, because methyl cellulose is very difficult to remove from the capsular cornices. So there are more chances of post-op rotation. Just stuck in there.
This part was fantastic.
And now, because of the high myopia this patient has got, in all post-op this patients, the eye should not be over-pressurized. Because if the capsular bag is inflated, then only there is chances of less rotation. But if the capsular bag is not inflated, don't stop the continuous inflation. Continuous, keep it on. So if the capsule, particularly in high myopes and in an oblique axis, there are high chances of this rotation. So give me the air bubble. So what I prefer is put the air inside. so that the lens is pressed and does not jump out of the recess, and it is compressed continuously. And I usually prefer a smaller canvas because that gives you more feel for all these things, like instead of 5 or 10 cc, I rather prefer to have 2 cc canvas for hydration. Like the report.
Sir, do you have any reservation of putting air in the anterior chamber in such cases?
No, I rather prefer to have the air because it will compress the lens backward onto the posterior capsule.
Very true. Very
true. In fact, if there is a very high myope or oblique axis, then you want to ensure, like in DSET, they put the air to press the button forward. Same way you put the air and there is no viscoelastic backwards and there is no leaking a wound, then probably the lens will not move post-operatively. 2, 5, 6. Right. And after the surgery, I usually, in this case, because this is myopic chamber, the incisions are not leaking, but I normally keep it pressed for 30 seconds to 1 minute like this and ensure there is no leakage from any of the incision. So if you keep it pressed, the posterior lip of the cornea will get lifted up and will get pressed over there. There will be no leakage. Instead of keep on hydrating the incision again and again, it is better to keep it pressed for a count up to 50 to 100. You will see there will be no leakage. Because I personally feel the main cause of endophthalmitis is ingress of the fluid. Because when you are operating, you have cleaned the cadaver sac completely with the betadine. There are plenty of fluid going. So there is the concentration of the bacteria are very low, even if they go inside the eye. It is after the surgery is over, and if the incision is not well sealed, when the patient closes his eyes, some of the fluid leaks out, and when he again opens up, the fluid gets sucked in. At that time, when the towel sac is not completely sterile, and that may be one of the major reasons for having endophthalmitis. Thank you very much. If there are any other questions, I'll be more than happy to ask.
Thank you very much, sir. Thank you very much. And in the last, when I put the 2 swabs, after completing the surgery, you need some patience to do this procedure, keeping these 2 swabs for some time.
Sure, in all patients, there's no leaking under any circumstances. Yes, many times I take even 2 minutes for this procedure, but that must be ensured. That must be ensured. And these 2 steps are very, very important. And don't keep the eyeball over pressurized, and don't keep on hydrating the wound time and again. If it is leaking, there is no point. If you hydrate it once, it is good enough.
Right.
And I usually prefer to put some amount of air because the air keeps on moving into the anterior chamber. So if there's some aggregates or something, information is coming, it will be liquefied, it will not get formed at one place. If by any chance any leakage is there, air will not leak out completely. And if there is an increase in IOP, probably air will cushion it better than the fluid. So even if the IOP goes up, the air can get compressed much more easily. So I usually prefer to put some amount of air in my patients. And it is absolute must for me in a toric IOL. So I do not use methyl cellulose in patients for the toric IOL at all.
Thank you, sir.
I use sodium iodide or use the iodine condition. Thank you very much, Dr. Bharti, for this excellent show over here. And the staff is very good. They're very cooperative, very understanding, and excellent OT. And thank you, Aircon, for a wonderful operating microscope and a machine.
Thank you, sir. Thank you very much. And you have explained everything while doing the operations. I don't think anybody has any question. Thank you, sir.
Please share the screen of OT2. We are closing the case there.
So this is AGV implant after closure is complete, and Dr. Manish will now just the speculum and the cornea.
That's the conclusion of surgery. So put up some sutures here, and I've tied it up with 10 more nylon on the sides. You can see the tube in situ. Since I've not made a side port, the pressures are a little low, so I think it will get built up in a day by tomorrow.
Very clean surgery, Dr. Manish. Fantastic. Congratulations.
Thank you. Thank you, sir. Thank you.
So that finishes our live surgeries from the OT complex. So we'll all proceed for the lunch.
आपकी ऑपरेशन हो गया है ठीक है आप क्या